Thanks everyone for coming. My name's Josh Sommovilla. I'm one of the colorectal surgeons here, and I work both in our Weiss Center for Hereditary Colorectal Neoplasia, as well as our DeBartolo Center for Young-Onset Colorectal Cancer. And thank you all so much for coming to our 9th annual Hereditary Colorectal Cancer Education Day, which now also includes education geared towards young-onset colorectal cancer. I'm just going to give a quick overview for the day before we get started with our program. So I'll be kind of moderating things for the bulk of the day with the help of David Liska, who's the head of our Weiss Center, another of the colorectal surgeons here, and Dr. Macaron, who's one of our gastroenterologists within the Weiss Center. And we've broken up the day into a few different segments themed around a few different topics that we think will be helpful to talk about. So the first is going to focus a little bit more on cancer genetics and our registry and what we hope to accomplish for our patients with our registry, followed by a short discussion, and then some updates on advances in genetics, polyp detection, and cancer treatment. And then our last session with some patient-focused topics geared towards helping you improve your quality of life as you're undergoing cancer treatments. And then finally, after all of those sessions, we're going to have a brief panel with a few of our patients that we've treated here to help give some helpful tips for people who might be going through struggles with either hereditary syndromes or young-onset colorectal cancer. Okay, so I'm going to talk a little bit about cancer genetics and really focus on, for both our hereditary cancer patients and our young-onset cancer patients, some of the distinctions between hereditary cancers and the genetics of colon cancer. So I think it's helpful to start with a couple of basic questions. The first of which is all cancer genetic? And the answer to this is yes. There's a genetic basis for all colorectal cancer and really pretty much all cancers that we get anywhere in the human body. But there's a difference between that and saying whether all colorectal cancer is hereditary. And the answer to that is no. And I'm going to get a little bit more into the details of these distinctions now. So when we look at the colon specifically, starting at this figure on the left, your colon is the last part of your intestines. It's your large intestine. It starts on the right lower side of your abdomen, and it goes up, over, down the left side, and out your bottom. And if we look at the colon at a more microscopic level, the colon is made up of layers. The colon wall is made up of layers. There's an inner mucosal layer, then a middle muscle layer, and then an outer layer. So this is looking at the colon wall kind of in cross-section here. And it's this inner lining, which is also called the mucosal epithelium, where pretty much all colorectal cancer starts. And this epithelium is made up of millions of cells that are constantly dividing and constantly growing, but also constantly dying off. And that's a well-balanced process in your body. This is just a more zoomed-in version of that epithelial layer of the colon wall. This is just another picture of all these cells on the colon wall. And basically what happens when a person develops cancer is that there'll be microscopic genetic changes that'll happen in some of these cells that'll allow them to divide in an uncontrolled way. And that balance between growing and dying falls off in favor of growth. And these cells will grow more and more. Eventually, they'll develop additional changes that allow them to invade, and as you can see in this further picture along here, into the wall of the colon, and that's a progression from a benign growth to a cancerous growth. And if you look at these colon wall cells on an even more microscopic level, every time these cells divide, you have chromosomes, which are further broken up into strands of DNA with genes, and these things all have to reproduce themselves whenever the cell divides into another cell. So in the process of the DNA duplicating itself, there can be errors that occur. And some of these errors allow the cell to grow in an unbalanced way. And so one way that our body is adjusted to this is by developing these proofreading genes that allow us to locate errors as our cells are dividing. And those cells will basically die off if they're caught by the proofreaders, and that'll prevent them from growing into a cancer. So either errors are found and they're repaired, or the cell is destroyed so that this doesn't propagate and grow into a cancer. And when we run into problems is if these proofreading mechanisms fail and errors get missed, then that can lead to cells with uncontrolled growth, which can become cancerous. And in the colon in particular, this has been studied a lot, and we found these abbreviations are just different genes that scientists have found over the years that are known to be prominently involved when colorectal cancer forms. So when this proofreading process doesn't work, these genes will develop mutations, and as we accumulate more mutations, that allows a cell to grow more than it should, which might turn into a polyp, which is a precancerous but benign growth. And eventually, if enough changes are accumulated, enough mutations happen, this will allow it to turn into a cancer. And this is just another depiction of that with a normal picture of a colon on colonoscopy here. This APC gene is one of the most important genes that we know is changed in cancer development. And as more genetic alterations happen over time, that can allow a polyp to grow, a polyp to get bigger, or adenoma is another word for a certain type of polyp. And then this can turn into an invasive cancer. And as I mentioned, we have these other genes called mismatch repair genes, and there are others too that really look after your DNA as it's dividing and try to identify these errors. And these genes are very important both in the development of spontaneous colorectal cancer, but in some of our hereditary cancer syndromes. And so these are just some of those DNA repair genes. As I mentioned, the mismatch repair genes, MLH1, MSH2, MSH6, and PMS2. These are the genes that are altered in Lynch syndrome. And there are other DNA repair genes mentioned here. MUTOIH is an important one, and then some other less commonly mutated genes that are important. So when we think about I think that's a good foundation for the genetics of colorectal cancer. And so we think about the genetic basis of colorectal cancer, that just means that it involves your genes and your DNA. But it doesn't really specify how these alterations may happen. So all cancer, including hereditary cancer, involves changes to the DNA in the cancer cells. Where we talk about hereditary cancer, this really involves a specific genetic mutation that's not just in the cancer cells, but it's present usually from birth and in pretty much all of the cells of your body, including the sperm and the egg. Now, there's some more variations of this where this is not 100% true all the time, but for the most part, that's what we're talking about when we're talking about a hereditary cancer syndrome. So these mutations are present in all cells of the body, but it often impacts the colon a lot because the colon cells divide a lot and there's a lot of room for more errors to occur. And so these genetic mutations give cancer a head start. Instead of waiting for these mutations to happen spontaneously, there's already one in every cell of your body, so it's just a few more that need to happen to develop cancer. And these syndromes are usually developed by having a cancer that runs in the family, having cancer that forms at a young age, and often cancer that forms not just in the colon, but other parts of the body as well. And when we think about these hereditary colorectal syndromes, we can break them down into a bunch of different categories, both by which genes are affected, but how they present themselves when we see them as people and as clinicians. So broadly, we can separate them into conditions where people develop a lot of polyps, and those are called the polyposis syndromes. Most common polyposis syndrome is something that we call FAP, where the APC gene, which I mentioned before, is mutated. I also mentioned the MUTYH gene before, and that's another polyposis syndrome. And here to the right, we see some of the less common polyposis syndromes that come from hereditary mutations. And I'm not going to get into all of those in this talk. And then we have our non-polyposis syndromes, the most common of which is Lynch syndrome. And I mentioned these genes before too. And this is when a person inherits or develops a germline mutation in a mismatch repair gene. And these are just some of the other repair mechanism mutations and the hereditary syndromes associated with them. And so just to kind of distinguish, as you might have noticed, those MSH mismatch repair genes, they're not the genes listed here in the process of colon cells developing into colon cancer, whereas the APC mutation gene is. And so just to give a little bit of a distinction between things like FAP and Lynch syndrome, I think of FAP as having a head start. So when you have FAP, you have a hereditary mutation of this APC gene, which is often the first step in forming polyps in cancer. So I would analogize this to really like starting a 50-yard dash, but starting on the 20-yard line. and getting a head start in a process, but you may be running at the same speed. Whereas with Lynch syndrome, because you have that mismatch repair problem, it really has a downstream effect on other genes and allows these other genes to mutate more easily without getting caught. So rather than having a head start, I think of this as just having an accelerated path where you might progress at a faster speed. Now, this is probably an oversimplification, but I think it's a good way to kind of think about how some of these hereditary syndromes are a little bit different from each other. So what about colorectal cancer in younger patients? As mentioned, these are not always from hereditary syndromes, but it's something that we're seeing more and more commonly in our society. And so this is just a statistical model that shows both the current trends, but also future predictions for development of colon and rectal cancer in different age groups. So as you can see, these graphs both start on 2010 and go until 2030. And you can see for the blue group, which is the youngest age group, people from ages 20 to 34, we expect in the colon these cancers to develop in the next 10 years by 90%, and in the rectum by 124%, while because of increased adoption of colonoscopy and other reasons, we're likely seeing a downtrend in these cancers happening in older patients. And so, that leads us to think, why is this happening so much more in younger patients? We talked a lot about the genetic basis of cancer, but all of this can't be really described by hereditary syndromes. There's got to be other things that are happening that are causing colorectal cancer to be happening at an increased rate in younger patients. And this is probably happening from a number of factors. There's things that have changed over time in our diet, in our environment, in our energy balance in our bodies that's likely allowing these colon cells to develop these changes that allow for cancer to form more easily. There are environmental hazards that are changing around us and in our environment. There are lifestyle changes that are happened in our population over time. We think there's a significant impact of the bacteria in our GI system that contribute to this. And of course, there's a genetic contribution to this, but there's no reason to think that these hereditary syndromes that really just don't depend on changes in your environment are increasing over time. So it's probably more likely, even though there are hereditary patients in these young onset group, that this is not what's causing the increase that we've been seeing over the past 15 years in this patient population. So these are just some of the factors that have been studied and shown to be associated with colorectal cancer in younger patients. One is having a more sedentary or less active lifestyle, consumption of sugary beverages, having high fat cells in the bloodstream, a high BMI, so obesity is associated with young onset colorectal cancer, fatty liver disease, and a Western diet, which we think of as having more processed foods and likely more red meat. Smoking, of course, is associated with colorectal cancer, and I mentioned meat and alcohol as well. This just shows some of the complex interactions that occur in our body between our diet and our gut bacteria and some other energy consumption factors that likely contribute to this rise in colorectal cancer. Now, just because we think that environment is a major contributor to the increase in young onset colorectal cancer, whenever we see a patient who has young onset colorectal cancer, we have to consider whether one of these hereditary syndromes that I discussed earlier could be a contributor to this. So Sarah McGee is going to be talking a little bit later about a little bit more of the details of genetic testing that we do, but genetic testing has become a lot easier to do in recent years. It used to be that we could really only test for one gene at a time, and it would be very expensive and it would take a lot of time to get these results. And now, fortunately, we're able to test patients with panels using either blood or saliva that test for whether a patient has a hereditary syndrome in dozens of genes, and often include all of the ones that we expect to see in patients with hereditary colorectal cancer syndromes. And even though we don't think that the hereditary syndromes are causing the rise in young onset colorectal cancer, we do see them more commonly in young patients. So if we look at patients in different age groups with colorectal cancer, we see, for example, in the youngest patients that more than a quarter of them will be found to have hereditary syndromes, whereas patients less than 50 but over 35 will be a little bit less than a quarter of them. And then in the older patients, it's around 10% of those patients. And as you can see, Lynch syndrome is the most common hereditary syndrome that we find, followed by familial polyposis. This is a study that we did on our own patients here at the Cleveland Clinic that was really consistent with what's been seen in bigger patient populations. So in our young onset colorectal patients, of those that underwent genetic testing, we found that about 21% of those did have a hereditary condition, the most common of which, about half of those had Lynch syndrome, and about 20% of them had familial polyposis, with a little bit more than a quarter of them having one of the less common colorectal cancer hereditary genes. So just to summarize, all colorectal cancer has a genetic basis, but that doesn't necessarily mean that it's hereditary. Young patients with colorectal cancer are at a higher risk from having hereditary syndrome, and that this should be tested for in all young patients who have colorectal cancer. But these hereditary syndromes are unlikely on a population level to explain the rise that we're seeing in colorectal cancer, which is likely to be more related to environmental factors.
Great. Thank you very much, Dr. Macaron, and thank you, Dr. Sommovilla, for a really excellent overview about the genetics and hereditary nature of colorectal cancer. So I'll be talking a little bit about the purpose and the role of our hereditary and young onset colorectal cancer centers. So first of all, talking about the hereditary center, and as many of you know, our hereditary center is called the Sanford R. Weiss MD Center for Hereditary Colorectal Neoplasia. And our mission at the Weiss Center is to prevent deaths from inherited colorectal cancer. And that's stating it quite simply, but a lot of work goes into that. So again, our goal is to prevent deaths from inherited colorectal cancer. And the way we do that is threefold. It's through patient care, education, and research. And I'll be talking about each one of these components of our mission separately here. So the number one goal of our hereditary center is to maintain the hereditary colorectal cancer registry. And people will often use the term registry and center interchangeably for us. And, you know, first and foremost, we need to understand what a registry is. Sorry, my slides are jumping. So colorectal cancer registry, really what a registry is a database or a list of patients and families. And when we talk about an inherited colorectal cancer registry, what it is a database of families and individuals with an unusually high occurrence or risk for developing colorectal cancer. And Dr. Sommovilla went over in some overview about the different syndromes that are part of our registry that make up hereditary colorectal cancer conditions. And like he said, the most common ones are familial adenomatous polyposis and Lynch syndrome. And one of the main jobs of our center is to maintain the registry, meaning maintaining accurate records of families and individuals. And the reason why it's so important to keep a registry and to keep these records is because we use these records to coordinate the care of these patients and to help figure out when they should undergo diagnostic testing, meaning to determine if they have a hereditary condition or if they have developed precancerous or cancerous conditions, to undergo surveillance, meaning to examine usually with endoscopy, upper and lower endoscopy, or scans to see if any cancer or polyps develop, and then to coordinate the treatment of these conditions. And I use the term coordinate here, and really the heart and soul of our hereditary center, and also really the engine that drives the hereditary center, are our registry coordinators. And many of you know them. And this is Lisa, Margaret, Susan, and Anna. And like I said, they are what make our registry work. And Susan will be talking a little bit more about the specific role of the coordinators. But just briefly, what they do is they maintain the database, they maintain the registry, they optimize compliance with surveillance by coordinating consults, testing, and treatment, and also serve as patient advocates and support. You know, the center, and what makes a center is really by coordinating care among multidisciplinary providers. And patients with hereditary conditions are in need of many different specialists. And, we have colorectal surgeons here, gastroenterologists, geneticists, pathologists, psychologists, advanced endoscopists, upper gastrointestinal surgeons, GYN oncologists, endocrine surgeons, urologists, breast cancer, pulmonology. And, many hospitals have all these disciplines at their hospitals, but really the goal of our hereditary center is to make sure that these different disciplines don't work in silos, because that becomes then very burdensome and confusing for the patients, but really work in a coordinated fashion. And I keep using the word coordinated because it makes a big difference if these different specialists work together for the patient, or if each one just focuses on their isolated specialty. And these are the different providers in our center. Again, these are just some of the disciplines that are involved. And again, the coordinators at the very top here, myself and Dr. Burke, who many of you know is our gastroenterologist leader for our center. And then we have the upper GI surgeons, more colorectal surgeons, endocrine surgeons, GYN oncologists, urologists, more gastroenterologists, advanced endoscopists, pediatric gastroenterologists, our genetic counselors, pulmonologists, breast cancer specialists, psychologists, and pathologists. So again, there's many different disciplines, and some patients will require other disciplines beyond that. And our goal at the center is really to make sure that all these disciplines work together for the benefit of the patient. So the next big aspect of our goals as a center and as a registry is to educate. And the education is really threefold. Number one, hereditary conditions are complicated. Dr. Sommovilla gave a very nice talk and tried to really simplify things, but they are complicated, and they're complicated for patients and families who get the diagnosis. And even though they will go to multiple doctor's appointments, it's not enough just to tell the patients what type of treatment they will receive, but a lot of patients really want to understand better why this is happening and how it's happening and what the future looks like. And our goal, really, first and foremost, from an education standpoint, is to help the patients and families understand what it means. And the families is really what's important. Every patient, no matter what condition they have, needs to be educated about their condition. But when we're talking about hereditary colorectal cancer syndromes, it's important that family members who might not even know about the condition that runs in the family, that they're educated about the risk of having it, so that they can also be seen by our center, by our genetic counselors, and determine if they have the condition and also need further care. The second goal of our education is to educate physicians. Hereditary conditions are quite rare, and many people don't know enough about it, even specialists. We did a survey a few years ago among colorectal surgeons to determine how much colorectal surgeons know about hereditary conditions. And really, the majority of colorectal surgeons know very little about it, just know the basics. And the same is true for other disciplines. So our goal is to make sure that we educate the other providers who take care of the patients, the primary care providers, the pediatricians, that they also understand what's going on in this specific patient's life, so that they can work together with the hereditary center and advance the care of the patient. So we'll have lots of patients who come from far away, and it is our job to not only treat the patient, but also communicate then with the physicians back at home for the patient, their primary care providers, their other specialists that take care of them, to make sure that everybody's in the same page and knows what's going on. And then lastly, another goal of our education is really to train and educate future hereditary colorectal cancer specialists, so that there are more people who are experts in the field, because we know that patients get better care when they're treated by experts within a hereditary center. So part of our center's mission is to make sure that there are more centers such as ours throughout the country, throughout the world, really, so that more patients have access to centers of excellence. And these are some of our recent graduates, so I'll talk a little bit more about this, but we were very fortunate to have, grateful patient endow a fellowship in hereditary colorectal neoplasia conditions. in honoring Dr. Church and Dr. Burke, who've taken care of so many patients. And we had 3 graduates go through our program, and each one of them is now active in hereditary colorectal conditions. We heard of Dr. Sommovilla, who's fortunately stayed here with us. And we also have Dr. Abbas, who is building a hereditary center in Chicago, and Dr. Smith, who just recently went to Australia and is working on starting a hereditary center over there as well. So again, and that's an important part of our mission, is to educate future leaders in this field. Now, the third component, like I said, of our registry is to do research. And again, it boils down to that these hereditary GI cancer syndromes are quite rare. And centers such as ours that have a large number of patients and families don't only have the opportunity to research, but really we have a responsibility to conduct research, because only centers such as ours that have the opportunity to treat patients can really learn more about the conditions we treat, since they are so rare, optimize the current treatments we employ, be it surgical or medical, and hopefully also develop new treatments that will improve the outcomes and quality of life of our patients. And that's a responsibility we take very serious here. And Dr. Anderson will be talking a little bit later today about some of the specific research that we just are working on here currently and recently. I want to go a little bit through the history of the Y Center specifically. Again, many of our patients have been here for a long time. Many of our physicians and coordinators have been here for a long time. And it really started back in 1979 when Dr. Jagelman, which is why our registry is named the Jagelman Registry, and he came here over from England, where he spent some time at St. Mark's Hospital, and they have one of the first and probably largest hereditary registries in the world. And he came over here to Cleveland in 1979 to start our registry, and he had a strong interest in hereditary colorectal conditions. And here in this picture, you see him with a family tree. And back then, they didn't really have all the genetic information that we have currently, and really it was only based on what the family looks like and how the inheritance pattern is happening, and what type of condition you can see with an endoscopy or during surgery. So back then there was a lot less information, and it really took sort of a vision to get a registry like this started. And then I think all of you know Dr. Church, and he came here in the 80s from New Zealand, and he took over the registry and expanded the registry to not only look at polyposis, but also at non-polyposis syndrome. Again, back then the gene wasn't really known, and then later on it became known as Lynch syndrome. In 2008, that's when our registry became known as the Y Center, when again a grateful patient of ours made a very generous donation, and that became the Y Center, with not only maintaining the registry, but also putting together a multidisciplinary team of experts that are dedicated to the care of patients who are at risk for hereditary colorectal conditions. Moving on, then in 2017, Dr. Matt Kalady, who many of you know, took over as director of the Y Center. And during those years was also when we started our first fellowship, and we just saw the fellows that have gone through here. Again, a grateful patient that made a very generous donation so that we can educate leaders in the field. And then I took over the center back in 2020. And then that was the year we also started our Young-Onset Colorectal Cancer Center. Again, a generous donation from one of our patients that made all of this happen. And just recently, we have another fellowship position. There will be a gastroenterologist. And that was in honor of Dr. Burke, who's been taking care of our patients for decades now. So this is the Jagelman Registry in terms of just looking at the number of patients that we are taking care of. We have close to 3,000 families with hereditary syndromes, about 4,500 individuals, and this is how it breaks up among the different syndromes. And again, it's a huge number of patients. Again, a huge responsibility and an opportunity for all of us to really optimize patient care, education, and research. And like I said, all this is only possible because we have a great team of experts and our coordinators to help take care of all these patients. So I want to move on to the young-onset colorectal cancer, and Dr. Sommovilla already gave a brief overview about this. And young-onset colorectal cancer can be due to a hereditary condition, but most often is not due to a hereditary colorectal condition. But what we have seen is in opposite to what we see in older individuals, where we have brought the incidence and mortality of colorectal cancer down through colonoscopy screening, unfortunately, we've seen this very alarming trend where in young people, the incidence and mortality from colorectal cancer is actually increasing. And already now, it is the #1 cause of death from cancer in men under the age of 50, and it will be soon the same in females as well. In 2020, there were about 18,000 new cases of colorectal cancer. And to put it into perspective, it's about 50 new cases of colorectal cancer a day in young people. And about 10 people a day in the United States die from colorectal cancer. And colorectal cancer really at any age is a very serious diagnosis and has a big impact. But I'll be going over why in people under the age of 50 it hits a little differently and really is the reason why we need to focus on these patients in a more coordinated fashion as a center. So that's what I want to talk about next is why do we really need a young onset colorectal cancer center? I think pretty much everybody for hereditary centers will agree that centers of excellence are important. However, for young onset colorectal cancer, with its recent rise, there's a lot fewer centers that really focus on this specific age group in a more coordinated fashion. And the three main issues really that I want to talk about is the clinical considerations, the knowledge gap, and a need for education and outreach. And that's really what our goal of our center is. So what are the special considerations? So Dr. Sommovilla already discussed this. He showed a slide that I'll share shortly here, is that the incidence of hereditary cancer syndrome is higher in young onset people. About 15 to 25% of young people with colorectal cancer, or 3 to 4-fold the number of older patients, will have a hereditary cancer syndrome. And if you're not going to check for that, you're not going to know about it. And we already discussed why it's so important for us to know if a patient has a hereditary cancer syndrome, not only for the patient themselves, but also for the family. So it is really important that every single young patient with colorectal cancer gets counseled by a genetics counselor and then tested. And this is, again, the slide that Dr. Sommovilla just showed a minute ago, where we can see in people that are really young, the incidence of hereditary syndromes, is about a third. Any patient under the age of 50, it's about, 20%. So that's, again, the majority are not due to a hereditary condition, but 20% is a significant number. And if you're not going to check, if you're not going to focus on this, then you won't find out. So that's why it's really important that all young people get tested. The other special consideration in young people is that, unfortunately, young people, many of them, about 40%, higher risk for advanced stage. When we diagnose a colorectal cancer, one of the most important aspects is what stage the cancer is diagnosed at. That's an important prognosticator, but it also informs what type of treatment the patient will need. And in people under the age of 50, as you can see here, they're more likely to have distant disease. What that means is that the cancer has spread from the colon to other organs. So when the reason for why that's happening, we're not entirely sure yet. A big aspect of it is because young people get diagnosed later, but it's possible also that young people have a more aggressive form of the cancer, and that's why they present with more advanced disease. But regardless of the reason, what it really means is that you have other considerations when you treat patients who have stage 4 or disease that has spread to other organs. And the reason for that is that in patients that are well selected, surgery on metastatic disease can prolong survival and offer a chance for cure. It used to be back in, not that long ago, when people had stage 4 disease or disease that has spread to other organs, that these patients will not be offered any other treatment other than just chemotherapy. And chemotherapy does not cure stage 4 colorectal cancer. There is a chance for cure in patients that are well selected by taking out not just the colon cancer itself, but also the deposits in other organs such as the liver, the lung, or the peritoneum. And young patients generally are better candidates for these complicated surgeries. And that's why it's really important that any young patient, even when they have stage 4 disease, is evaluated at a center that has access to these specialists who do surgery on cancer that has spread to other organs as well. So, like I said, about 40% have a higher risk for advanced disease. These patients have a good performance status, meaning they're generally younger people are healthier, and when you can treat them more aggressively by both surgically taking out those deposits in other organs, but it is critically important that it's not done in silos again. You don't want sort of the patient to see a liver surgeon who says, yeah, I can take out that part of the liver. And then the colorectal surgeon says, yeah, I can take out that part of the colon. But if it's not done in a multidisciplinary fashion where we're treating the patient as a whole, sometimes patients will get inappropriately treated. So it's really important that all this happens in a coordinated fashion as part of a center that takes care of the entire patient. Another special consideration I want to talk about is that young onset tumors, we know that they occur in different parts of the colon, predominantly on the left side. So about 40% of all young onset colorectal cancer patients are in the rectum or rectus sigmoid, which is higher than about 30% that we see in average onset colorectal cancer. So when we're talking about rectal cancer, there really is a need for multimodal treatment, meaning people with rectal cancer often need, besides surgery, need radiation, chemotherapy, and surgery. So again, when you have multiple disciplines involved, you need to do it in a coordinated fashion, that they work together, but also the effects of treatment specifically for rectal cancer, including the radiation and chemotherapy, can have significant sequelae, significant consequences on long-term functional outcomes. And one of it that we really only worry about in young people is infertility. Radiation and chemotherapy can cause infertility. It can cause sexual dysfunction, it can cause bowel dysfunction. And people with rectal cancer often need either a temporary or a permanent ostomy, which also causes quality of life considerations that need to be addressed carefully. So when we talk about female fertility preservation, the radiation can affect fertility in female. It almost always does, but there are some ways how we can prevent that from happening. Young females who are still planning on having family, when they need chemotherapy, there's certain medical therapies that you can do to protect the ovaries and the oocyte production. And there's way to, even when they undergo radiation and surgery, there's ways to preserve the embryos, the oocytes, and there's some surgical procedures we can undergo to protect the ovaries from having radiation, and where we'll have gynecologic surgeons go in before the radiation to take the ovaries out of the field of the radiation, or sometimes even take a part of the ovary and freeze it so that when the patient is done with treatment can then still become pregnant. So again, this is something that needs to be at top of the clinician's mind when they see a young person with colorectal cancer, with rectal cancer specifically, so that fertility can be preserved. And again, when you have a clinician who's only focusing on one aspect rather than the patient as a whole, sometimes this gets overlooked with permanent consequences for the patient. Besides that, we know that young people are more susceptible to psychosocial distress related to their diagnosis and treatment. Again, no matter what age you are diagnosed with colorectal cancer, and no matter what the reason is for the diagnosis, if it's through a hereditary condition or without a hereditary condition, when cancer hits a young person, there's more emotional distress and anxiety, and we'll talk about the psychological implications a little later today. There's more fear of the procedure among young people. There's a greater struggle with the changes in physical appearance. We spoke briefly about the need for stoma in some cases, and young people have a harder time with that. Young people are often in the peak of their career when they get diagnosed. It's harder time managing work. About 80% of young people with colorectal cancer have children under the age of 18. So it's extremely difficult to manage all your cancer-related care while taking care of young kids. And then lastly, the financial toxicity is something we can't underestimate. Young people, again, they don't have as many savings as older people. They're in the middle of their careers. Having a cancer diagnosis that not only costs a lot of money from a medical care standpoint, also takes people away from their jobs where they're not having the ability to earn money. So there is an extremely strong need for psychosocial support for all these considerations. So just to summarize, throughout all the different phases of care, there are different aspects about young onset people that need to be focused on in a coordinated fashion. We want to make sure at the time of diagnosis that we don't delay the diagnosis in young people. And when a young person has symptoms that are concerning for colorectal cancer, we need to make sure that these are taken seriously and worked up. We need to make sure that we talk about a family history, and we need to identify hereditary colorectal cancer condition. During the treatment phase, when there's advanced stage disease, meaning it's spread to other organs, we need to make sure that these patients are given a chance for a curative approach, but it needs to be done in a personalized and a coordinated fashion. And during the treatment, we need to make sure we preserve quality of life and fertility. At the survivorship phase, meaning after treatment, we need to make sure that we focus on what really is the risk for subsequent cancer. We need to make sure that these survivors have the appropriate psychological and social support. We need to focus on sexual health of these patients and on holistic wellness. And we'll be talking about that in the third session of today. And then we need to prevent cancer. And the only way we can prevent cancer is by screening, by talking about some of the lifestyle changes that people can have, and recognize any potential risk factors for the condition. And that is really the goal of our center that we started here a couple of years ago, is really to optimize outcomes for young patients with colorectal cancer through a comprehensive, but again, coordinated multidisciplinary care through research, education, and outreach. And we do this with clinical coordinators, genetic counseling, fertility preservation, and sexual health. We expand the treatment for stage 4, psychosocial support. We have integrative oncology and lifestyle medicine, and a strong focus on surveillance and survivorship. That's from the patient care standpoint. From a research standpoint, again, we have a prospective registry. We're collecting biospecimens so that we can study them, and we're looking at environmental exposure data to figure out what are really these risk factors that can cause this rise in young onset cancer. And then lastly, we're doing education, such as our event here today, outreach so that people understand what's happening. And we really are very fortunate to have patient advisors who help us understand what we need to focus on, that serve as advocates and help also with support of other patients and survivors. Putting it all together, we have a patient education handout. So because it's quite overwhelming just to get a diagnosis of young onset cancer, and then to focus on all these different aspects of the care that might be involved is extremely overwhelming. So we put together this handout that we give all our patients now so that they understand all the different specialists and centers that are involved in their care. And really, again, it comes down to a team of people. We have, again, a large group of colorectal surgeons that are interested in it. We have amazing oncologists, radiation oncologists, fertility specialists, sexual health specialists, maternal fetal medicine patient, urologist, genetic counselors, pathologists, liver surgeons, gastroenterologists, genetic researchers, wellness and lifestyle specialists, psychologists, and again, the heart and soul are our coordinators and administrators, and again, the social workers as well. So again, it takes a team, and really our goal is to provide the best possible care, educate, and do research. So thank you, and please feel free to ask any questions in the chat.
Hi, good morning. Welcome to our colorectal cancer education day, including our hereditary and our young onset. My name is Susan Milicia, and I'm one of the clinical research nurse coordinators within our department. And I am here today to tell you a little bit about what our role in the registry is. So first, let me introduce you to our center. So the Sanford R. Weiss Center for Hereditary Colorectal Neoplasia includes the David G. Jagelman Inherited Colorectal Cancer Registry, and also the Edward J. DiBerlardo Jr. Family Center for Young-Onset. So the people that work in those departments, most of you are probably familiar with the hereditary team. That's Lisa, Margaret, myself, and Anna. And Sophia and Catherine work in our Young-Onset Center. So really quick, what are the differences between young-onset and hereditary? So a hereditary colorectal cancer is a genetic mutation that occurs at conception. It's most often passed from parent to child, and there's a high risk of cancer in other organs. A lot of times you'll see a very strong family history in patients with hereditary cancer syndromes. And for the registry purposes, sometimes we'll follow patients that do not have a genetic mutation, but they meet other kind of criteria to be in the registry. And sometimes that can be the number of polyps they have, or family history and personal history, things like that. And then our Young-Onset Center is for our anyone diagnosed with a colon or rectal cancer under the age of 50. So it's not the result of a genetic mutation, and they may or may not have any family history of cancer. A lot of our Young-Onset patients come in and no one in their family has had any kind of cancer before. So let's talk about our mission. So the mission of the White Center is to prevent death from cancer with individuals with a hereditary predisposition for colorectal cancer syndromes, and now we're including young-onset. We want to provide the best care to patients and families, promote knowledge of the risks and implications of a family history of colorectal cancer, and then to conduct important research in areas of concern. Our research study is designed to answer specific questions about new ways to prevent, detect, and treat disease. So how do your coordinators help do all of this? There's three things. There's education, research, and patient care. So the first, education. We want to teach our patients and families everything there is to know about your syndrome or your illness. We want you to know what kind of screenings you need, the treatments, what you need and why you need them. We want to educate your care team. So if you're not being seen here by the clinic, we can work with your local care team to make sure they know what's going on with you and what the best treatment plan is. We're also very active in national meetings and have important leadership roles in national and international societies. Because education is very, very important to the Cleveland Clinic. So next, we do research. So about 5% of colorectal cancers are the results of a hereditary condition. And then the incidence of young onset cancers is really going up. So a lot more research is needed. We have a database it's called Cologene, where we collect patient information. So that information we collect on you. Things like your personal health information, things like if you've had cancer before, or the screenings you've had and what the results are. We want to know who you are and where you are. And we have hereditary and young onset meetings separately twice a month, where the specialists on each team come all together and discuss hereditary and young onset, but they discuss patient care, education, research ideas, and projects. And then the family tree. So one of the first things we put into Cologene is your family tree. And this helps your coordinator at a quick glance see what kind of screenings you need, especially for hereditary patients. So an example of that would be a few years ago, we did some research on our Lynch patients when it came to cancers in the urinary tract. So we used to do a urine analysis for every single Lynch patient that came in every year. What we found is that wasn't a good test. It never identified a cancer in the kidneys and the ureters or the bladder. So we stopped doing that, and we did research, and we found what makes certain Lynch patients at higher risk for the cancers in those organs. And so we kind of condensed that list to who needs to see urology. And then we still don't necessarily do a urine analysis. We do some further workup that can be like cystoscopies or ultrasounds and things like that. If you want to know the details of that, just give us a call. And then again, in our research database in Cologene, so we're going to enter all your personal and family history of cancers, all your test results. So if you have a colonoscopy, we want to see how many polyps you had and what the pathology was. If you've had any imaging done, we'll keep that in there. Seen a dermatologist, gynecologist, we'll want to keep track of everything, because a lot of times especially with hereditary patients, if you're at risk for colorectal cancer, you're again at risk for cancers in other organs. We use Cologene to send reminder letters to our patients when they're due for screenings. Some patients come every 6 months, some come every year, and life happens and it's hard to remember when to come back and plan. So we do our best to send you a reminder letter about 3 months before you're due. So after we put all this information in our database, we can query all that information out and do research. And then that research helps us guide screening recommendations, just like the urinary example we just talked about. So I don't have a photo of one of our team meetings. I have kind of an example of what our team meetings look like. So here they are. We used to have our meetings in person, but since COVID, we've had everything virtually. So this is really what it looks like, except with our providers. So we went over education and research. The next thing is patient care. So we can schedule you with our hereditary multidisciplinary team, or we have young onset cancer subspecialties that we can schedule you with depending on what you need. So our hereditary team includes the following, and to go into a little more detail, your colorectal surgeon can do your colon screenings, provide surgery if it's needed. Your gastroenterologist will survey your GI tract from your stomach down to the rectum. The urologist is going to look at your kidneys, ureters, and bladder. Endocrine for thyroid screening. We have a gynecological oncologist team that survey the endometrium, the uterus, and the ovaries. They can also do preventative or treatment surgeries if needed. Dermatologists, they can diagnose and treat any skin conditions. So certain hereditary syndromes put you at risk for certain kind of skin cancers. But the dermatologist is not only looking for that, but they're looking for any cancer or anything that needs to be addressed. And then we also have psychotherapy. So we have a team within the therapy department that assists with coping skills. They can help with ongoing therapy for anxiety, depression, stress-related symptoms. And they can also do consults for just very specific issues. So if you just want to talk to them one time about, how to talk to your child about your diagnosis or about your genetic syndrome, they do that too. And then the cancer-related subspecialties, there's quite a few over here too. So they would still see the same as the hereditary ones. All those hereditary multidisciplinary specialists, they would see that team, but then they can also see genetics. So genetics, if a patient has a genetic syndrome, the treatment and surveillance can be different from those who don't have a genetic mutation. So we always want to know, especially if you're diagnosed young with a colorectal cancer, we want to know if it's hereditary or not. We'll have you see a medical oncologist and a radiation oncologist, and they're going to do a comprehensive individualized care plan to kind of help you with your treatments before treatment, during treatment, after treatment, with the goal of really minimizing toxicity and side effects. We have a liver, thoracic, and general surgery team. So young onset patients are more frequently diagnosed with colorectal cancer at an advanced stage, with cancer spread to other organs such as the liver and the lungs. So to really maximize survival and cure, our patients are seen by thoracic surgeons, liver specialists who are again specialized in treating colorectal metastasis. And then we have psychology again. So for all the same reasons, you could see psychologists for hereditary. For the young onset patients, young adults confronted with cancer diagnosis face challenges outside of the everyday experience that could include disruption of your life plans, like your work plans or your education, your relationship. It can affect decisions about treatment, trying to parenting your young children while you're sick, reshuffling family roles, managing symptoms like fatigue and pain, sleep, and coping with uncertainty. So our team includes a clinical psychologist with expertise in providing psychological support to young people with cancer. Moving along, we have some more cancer-related subspecialties. There is pre-treatment fertility and preservation for both men and women. So male fertility is really relevant to see one of our fertility specialists because some of our young onset patients are not done completing their family. Chemotherapy, radiation, and surgery can all affect a man's ability to father a child. So we want to make sure those patients are offered counseling regarding the effects, as well as options for fertility preservation. For women, we have a fertility preservation program, provides comprehensive reproductive care to allow future fertility and a better quality of life to our young onset patients. Reproductive endocrinology, physicians provide very tailored consultations on the impact of cancer treatments on fertility and identifying the best fertility preservation approach for each patient. And again, this helps patients if they want to preserve or extend their family after treatments. Then we have hormonal and sexual health for men and women. For men, they can address sexual functions after treatments, such as erectile dysfunction or pain, or any other abnormalities. Sexual health for women, it's kind of a hormonal and sexual health for women. So it's kind of on the opposite spectrum of the fertility, where we focus on menopause or contraception in medically complex individuals. So women with a history of cancer can have complex health needs. A female sexual health program cares for women that have concerns about issues related to hormonal changes and sexual concerns. For example, cancer treatments can lead to symptoms for women, which can include pain during intercourse, urinary symptoms, and early menopause. So lack of estrogen at a young age can not only impact the quality of life by causing those kind of bothersome symptoms, like sleep disturbances and hot flashes, mood changes, but it can also lead to an increased risk of heart disease, osteoporosis, and other medical conditions. So we offer the hormonal and sexual health for our women that have a young onset cancer. It's also offered for our hereditary patients that need it. All of these subspecialties, even though I say young onset, it's really for anybody, but I'm focusing on young onset. Then there's lifestyle and wellness. The Lifestyle Wellness Center really wants to focus on the whole person. So they cover a variety of conditions or medical concerns, including cancer prevention, lifestyle modification, pain, digestive problems, fatigue, stress. And some of the things that they can do are acupuncture, nutrition counseling, psychotherapy, chiropractic care, massage therapy, yoga, personal training, and they even have vitamin and supplement counseling. So the role of the registry coordinator, pretty much everything that we just talked about, the registry coordinator is responsible for setting up for our patients. So we, as the coordinators, we educate our patients and families on their cancer risks, their screenings, their family risks for cancers. So you know what syndrome you have or your cancer diagnosis. We want to make sure you know everything that you need to know, offer you all of these subspecialties, and get everything that you need. Then the research coordinators help conduct important research. So again, we want to try to prevent, detect, and treat disease. And then probably 95% of the coordinator's day is spent with patient care. So we kind of say we're the quarterback to your care. We help guide you through this whole process. It can be very overwhelming. We do our best to try to schedule everything in one day or one trip. Shop. So we try our very best to do it in one day, but sometimes depending on who you need to see, it can be over a day or two. And we are also responsible for gathering all of your outside information. So if you've had surgeries in the past at other hospitals or screenings at other places, we want to gather all your records, put everything together, and then your coordinators write something that we call an abstract. And what we do is write for the physician, basically your story. So what brought you into us, if you have a hereditary syndrome, what kind of screenings you've already had, and what you need from there. And then the physicians look those over and go through it and decide, what kind of treatments are best for you and what you need. And then we all work together as a team to get it done. A little bit more on the role of the coordinator. So We also put together a family newsletter. It's called Family Matters. We put it out at least once a year, but we try for twice a year. That has just patient stories, education, new updates with genetics or stuff like that. We give you all sorts of good stuff, good information in there. We coordinate the Hereditary and Young-Onset Health Education Day like we're doing today. We also coordinate the Walk to End Colon Cancer. I believe this year was our 7th year, where we have a walk downtown every year in the fall and September, and we help raise awareness for colorectal cancer. We also track what we call productivity. So every time our patients come in, we do our best to know about it. So we want to know when you're coming in so that we can make sure that when you come in, you're getting everything that you need while you're here. And it helps us to make sure that we're doing the right things for everyone. And so really, the role of the coordinator is to get you the care that you need, no matter what that it may be. And if we're not the right person to schedule something, we'll get you in touch with the right person or department to get you what you need. But most of everything that you may need is within our department. So that's pretty much everything. I will not be available for the Q&A after, but one of my coworkers will be. So if you have any questions, ask during the Q&A or give us a call. Take care. Thank you.
Good morning. It is a great pleasure to be here, to be a part of a terrific session, and to discuss a little bit of our group's research over the past 3 years. Next slide. Can the slides advance? Next slide. We are fortunate that there's been great worldwide interest in our research, and this has resulted in approximately 150 publications in 3 years and presentations at multiple national and international meetings. Our group members sit on committees responsible for developing national guidelines in both screening and treatment options for our patients. But in truth, the real credit for this enormous productivity goes to our patients, who volunteer to participate in research that will benefit not only themselves and their families, but also people throughout the world that they will likely never meet and our future generations. So thank you. So I know you don't have time to listen to me discuss all 150 papers published today. So I had the difficult task of sifting through this important work to identify the studies that I thought would be the most interesting to discuss. I thought it would be useful to include a few papers on Lynch, on young onset colorectal cancer not otherwise specified, and on FAP. Next slide. So the first 2 papers I'm going to discuss examine screening recommendations for patients with Lynch syndrome. Next slide. So while colonoscopy surveillance is well established in Lynch, the benefit of upper endoscopy surveillance is less well defined. Our group looked at 323 patients in our registry who underwent EGD every 2 to 3 years. We found that 1 out of 6 patients had an important finding on EGD, and out of these findings, 1/4 were found on initial EGD and 3/4 were found on follow-up EGD. Findings that were important included identification of precancerous lesions and infections and 5 early-stage cancers, which were identified before they were spread and therefore were still curable. And so with the results of this, we recommended EGD every 3 years for patients with Lynch syndrome. Next slide. On the other hand, while screening is important, it is essential that screening actually benefits our patients. We want to minimize unnecessary testing as we know it adds cost, inconvenience, and stress to our patients. Our group carefully evaluates the testing we are doing and sometimes finds that tests are not necessary. And this was the case, as you heard in our last session, for urine testing. We know that patients with Lynch syndrome are at increased risk for urinary tract cancers, and so we had been doing routine urine testing to screen for this. However, when we examined our data, we found that urine testing was actually not effective. We examined 204 patients without symptoms who had yearly urine testing over a 10-year period. In this time, almost 1 out of 10 had an abnormality, which resulted in further testing being recommended. However, no cancers were actually found as a result of all this testing. On the other hand, 5 patients did develop cancer, and they notified us of symptoms between their screening tests. And 4 out of these patients had had a routine screening test, which was normal within the past year. And so therefore, we stopped asking patients to do the urine testing as it did not actually improve their care. Next slide. Next, I would like to discuss two papers looking at the distribution of young-onset colorectal cancer, which, as Dr. Sommovilla and Liska discussed earlier, is becoming an increasingly important problem. We understand that colorectal cancer is influenced by both genes and environment, as again you heard earlier today, and so we wanted to examine some of the environmental contributions to this important disease. Next slide. We looked at large national databases to understand the geographic distribution of deaths due to young-onset colorectal cancer, and we found that there were hotspots in the US where young-onset colorectal cancer was significantly more common, as well as cold spots where it is less common. I want to draw your attention to the bottom figures of the slide, which are adjusted to remove other factors which influence colorectal cancer and therefore just focus on geography. What we found is that in all patients under 50, there are hotspots, and those hotspots are circled in red. Hotspots in the southeast, where there's a 25% higher chance of developing young onset colorectal cancer, as well as cold spots. So there's hotspots in the southeast and in the Great Lakes region. And then there are cold spots in lower Wisconsin, northeast, southwest Texas, and the western US, including Alaska. And then we also specifically wanted to look at the geography of our youngest patients. And these we defined as under 35 years of age. So this group is in the bottom middle picture. And here we found hotspots in this group in the Northeast, the upper Midwest, and we found cold spots in the Southwest California and the Mountain West. So understanding this geographic distribution is important because it will help us identify opportunities to best allocate resources and to help prevent deaths and ideally prevent this disease altogether. Next slide. One question that naturally arises is whether there are differences in colorectal cancer based on racial identity or socioeconomic status. We felt that this was a very important question for our young onset patients, and so we decided to take a look at the data. We found that racial disparities are magnified in young onset colorectal cancer. The pie chart on the left shows the overall racial breakdown of cancer, and you can see on the right of the screen that the under 50 colorectal cancer patient is significantly more likely to be non-white. There is an approximately 4 percentage point increase in the prevalence of young onset colorectal cancer in patients who identify as Black or Hispanic, and a slight increase among Asian identifying patients. Next slide. We also found that Black patients had shorter survival and worse outcomes, and these trends held true even for patients who had private insurance and even in communities which had higher income and education status. And this suggested that there are systemic biases beyond those associated with socioeconomic disparities contributing to these disparities for our patients. Next slide. Finally, I would like to spend some time discussing our research in familial adenomatous polyposis. Next slide. We have made great progress in decreasing colorectal cancer deaths from this condition by recommending removal of the colon at a young age. However, we knew that duodenal cancer, which is cancer of the first portion of the small intestine, continues to be a significant problem in our patients, and it's the second most common cause of cancer deaths after colorectal cancer. 100% of patients with FAP will develop duodenal polyps over their lifetime, and 4.5% will develop duodenal cancer by age 57. In a perfect world, we would remove the duodenum just prior to cancer developing so that patients could live as long as possible without this additional surgery, but still never develop cancer. Next slide. We realized that traditional staging systems were actually underestimating the risk of duodenal cancer for our patients. So the traditional staging system is called the Spiegelman classification, and it's here on the slide. But essentially, it looks at the amount and characteristics of duodenal polyps, and based on the results of the staging system, recommends EGD surveillance at intervals ranging from 3 months to 5 years. And then in the case of more advanced polyposis, recommends preventative surgery. In the traditional system, if the staging is 1 to 3, there's thought to be an under 3% chance of duodenal cancer over the next 10 years. But in stage 4 patients, there's a 1 in 3 risk of cancer in the next 10 years. And so these patients are recommended to consider preventative surgery. We found that half of duodenal cancers in our patients never had stage 4 polyposis. And we also found that polyps over a centimeter in size and with a normal appearance under the microscope were the most likely to be risk factors for cancer development, and actually were as important as the overall Spiegelman stage. Each factor increased the cancer risk by between 3 and 4 times. So we believe that many of these cancers were developing without significant polyps, and that these particular cancers were due to cancers in what's called the papilla, and that's the exit for the pancreatic and bile drainage system, from the pancreatic and bile drainage system to the first portion of the small intestine. So that's shown in this picture here, the little dot in the center. We realize that when patients are undergoing their upper endoscopies, it is crucial that the endoscopists evaluate the papilla. Next slide. We followed up this work with a study looking at the natural history of ampullary polyps. And when we looked at 143 patients over approximately 8 years, we found that about 1 in 4 would exhibit what we called clinically significant worsening over the surveillance interval. Of these, most would grow larger or look more concerning under the microscope. Only a small few, though, would actually develop into ampullary cancer. So we therefore recommended very close surveillance of these patients instead of rushing into preventative surgery. Next slide. Finally, we wanted to understand how we should perform this surveillance, and most importantly, whether we should perform biopsy sampling of the papilla, as this can result in a complication such as pancreatic inflammation, also known as pancreatitis. We looked at the result of almost 800 EGDs in almost 300 patients, and actually we found an extremely low risk of pancreatitis, under 1 in 100. However, almost 1 in 7 patients had an increase in the staging of their duodenal polyps due to the biopsy results. And of these, half of the change in management occurred when the papilla actually looked normal under endoscopic magnification. Therefore, the magnified appearance wasn't enough for these patients. Rather, the tissue had to be sampled and examined under a microscope by a pathologist. Importantly, the results of this biopsy led to recommendations for preventative surgery in 8 patients, or 3% of our group. Next slide. For the final topic I'm going to discuss, we looked at the results of our preventative colon removal in our patients with FAP. One of the more difficult problems in familial adenomatous polyposis is something called desmoid disease. Desmoids are non-cancerous tumors, which, although they are technically benign, can grow large and cause many difficult symptoms for our patients. They can make further surgeries more challenging, and they're very difficult to treat. Our group wanted to see if the type of colon surgery patients underwent might influence how likely they were to develop desmoids. Next slide. The 2 most common preventative surgeries our group performs for patients with FAP are removal of the colon, called a total abdominal colectomy, which is the picture on the right-hand side of the screen, or we sometimes remove the colon and the rectum, and this is called a total proctocolectomy. Next slide. We then reconnect the gastrointestinal tract by either connecting the small intestine, called the ileum, to the top of the rectum if we left the rectum in place, which you see here, or next slide, when the rectum is removed, we can make a substitute pouch of small intestine called a J pouch, which then attaches to the anus. Next slide. So our group hypothesized that the J pouch surgery, where the entire colon and rectum were removed, was a relative risk factor for desmoid development due to increased stretch and trauma to the small bowel mesentery that occurs when we create a pouch. Next slide. We looked at our experience of 345 patients over 20 years and found that patients who underwent a J pouch had a 6.5 times higher risk of developing desmoids as those who underwent surgery, which kept the rectum in place. In fact, type of surgery was a more significant risk factor for desmoid disease than previously understood risk factors such as family history of desmoids or desmoid risk factor score. So based on these results, we try to preserve the rectum in our patients whenever it is safe to do so. Next slide. Of course, some patients will need to undergo J-pouch surgery, usually because of precancerous polyps in the rectum. Some of these patients will have problems with their substitute rectum. Pouch inflammation is a common cause of pouch problems in patients who undergo pouch surgery for another type of disease called inflammatory bowel disease. And so doctors may suspect pouch inflammation in patients who have a J-pouch for FAP. However, when we looked at our data, we could not find any patients with FAP who had true clinical pouchitis, although almost 1 in 6 were told by other physicians that this was the cause of their symptoms. When we looked at our data, we found there was usually another explanation for the symptoms and one we could treat to help the patients feel better. Next slide. The final topic I'm going to discuss is the risk of cancer or precancerous areas after pouch surgery. When we remove the rectum in J-pouch surgery, we leave the anus, and there are always at least a few cells of rectal tissue left behind. In some patients, these can eventually turn into a cancer, and so it is important that we watch these patients closely. We looked at our experience and found that almost half of patients with J-pouch surgery would develop precancerous lesions or adenomas, but most of these would not actually develop cancer. Of the cancers which developed, only 3 developed when the patients were being watched, and only 1 developed while the patient was under very close surveillance. The treatment or preventative surgery for these patients who develop cancer is removal of the pouch and anus and a permanent ostomy bag. We found that the majority of patients could avoid this by undergoing very close surveillance, which is terrific news. Next slide. So I know I discussed a lot of different topics, and trust me, there are many, many more that I didn't discuss today. But I hope this gives everyone a sense of the impact research can make on our patients with all types of diseases and conditions. Next slide. Our ultimate goal remains to both prevent cancer and to keep function as normal as possible for as long as possible in all of our patients. Thank you.
I would like to invite all the speakers to come off mute and turn on their cameras. We're gonna go ahead and get started with Q&A session. I do already have a few questions in the chat box. I know Dr. Liska mentioned that a significant proportion of our patients are from out of town. Some patients are in the registry, may seek some care locally. There's a question whether information could be provided on what they need to make sure that they are up to date and on track with the test and prevention that they need to do.
Yeah, I think that, that's an excellent question and a really important one too. And yes, when you are from out of town, you can still be part of the registry, and we have family members that are part of our registry, even if they've never come here to the Cleveland Clinic. And I think Margaret is here, and she can maybe talk a little bit about how exactly the process would work for somebody who's out of town and wants to get some information from the registry.
Oh yeah, absolutely. Anyone can be part of the registry. You don't have to be a Cleveland Clinic patient or come to Cleveland. We're happy to help. We can talk to you over the phone, send you information via email or snail mail, and stay in contact with you, with your local providers. And we'll just ask that you let us know where you've had your screening or surgeries done so we can obtain those medical records and then stay in contact with you and keep you updated.
Okay. And another interesting question, I'm not sure if Dr. Hurley is here, but a patient is asking what research has been done on the impact of childhood trauma and other diagnosed trauma and their impact on cancer. I know Dr. Hurley has been looking into early childhood exposure and trauma and their effect on cancer. If she's on, I would really appreciate if she could come off mute and talk. If not, we will be happy to share this information with you.
Yeah, I don't think Dr. Hurley is here yet,
Not quite
but I
yet.
think it's an excellent point, and really the question of what is driving the non-hereditary young onset cancer is really the crucial question that we're all trying to figure out. And it is a tough question because it is probably not one thing, and it's probably multiple things. And the timing of when that impact happens is also not entirely clear. But there is some evidence that even in utero exposures can lead to young onset cancer. So definitely things that happen during childhood, be it environmental, maybe psychologic, could have an impact as well. We know that survivors of childhood cancer and who are treated during their childhood for cancers are at higher risk for young onset colorectal cancer. And the thinking is that it's probably related to some of the treatments they had, but it could potentially be related to other type of trauma. So this is a really, very, very important question for us to answer. And really, the only way we can answer it is by looking into it and by having patients answer questions about their exposures and experiences throughout their lives.
So thank you for the opportunity to talk today. Like Josh said, I'm one of our genetic counselors here at the Weiss Center and the Young-Onset Colon Cancer Center. And I'll be talking about advances in genetic testing and more. So, learning objectives, we'll talk about advances, when we will consider additional genetic testing, and, discussing health information with family members. So first, we'll kind of talk about how genetic testing has changed. So prior to 2013, testing really included looking only at maybe a few genes at one time. And the genes we were looking at were the ones that were most closely related to the features that we were seeing with an individual. So if someone had a lot of colon polyps or polyposis, we may have been only looking at 1 or 2 genes related to polyposis. Or if they had young onset colon cancer, we were mainly looking at just those Lynch syndrome genes. And so you can kind of think about this as we're only looking at a book or 2 representing a gene, looking for any spelling errors in this book and any missing or extra chapters that may be a mutation in the gene. After 2013, we started testing many genes at one time that were related to multiple different types of cancer. We often refer to this as multi-gene panel testing. And with this, we were no longer focusing on genes just related to an individual's symptoms, but looking at genes related to all different types of cancer. So this is us kind of looking at a collection of books and looking at all of these books for any spelling errors or any missing or extra chapters. Other people may have undergone testing called single site mutation analysis. And this is when we test for a mutation that we know already in your family. And so this is where we, know exactly what book to look in, and we already know exactly where to look. And we're only looking in that one spot to see if there's that same spelling error or if that same chapter is missing or the same chapter is extra. And kind of the reason why testing has changed over time is our technology has changed. We now have easier ways to look at all of these genes, so it doesn't take as much time. But also the number of genes that we know of in general has increased. So this timeline really focuses more so on genes related to colorectal cancer and colon polyps. So as you can see on the left-hand side, in the late 90s, early 2000s, we did identify a number of genes. And these are the genes for conditions that we've heard a couple of times today. So genes for Lynch syndrome, familial anematosis polyposis, and MUTYH-associated polyposis. And these are kind of our more common hereditary cancer syndromes related to colon cancer and to colon polyps. And since we have known about these genes longer, we kind of have more information about these genes because we've had more time to study them. So we have a better idea of the cancer risks associated with them and how best to take care of people if they have one of these mutations. These genes and these conditions that they cause are also more common compared to these genes that we see over on the right-hand side. So these are genes that we have more recently discovered that if someone has a mutation or mutations in these, it can also cause a hereditary colorectal cancer syndrome or a polyposis syndrome. But with these, we do see these less often typically than the genes that we found earlier on. And since these genes are newer, we haven't had as much time to study them, and we haven't identified as many people that have mutations in them. So we don't know as much about them, so we may not know as well what the true cancer risks are when someone has one of these mutations and how best to take care of them. But since we've discovered these extra genes, we have been adding them in, more and more into our multi-cancer panels. And this figure is only going over those genes related to colon cancer. The same kind of phenomenon has happened with other types of cancer. So the same thing has happened with breast and ovarian cancer. So our number of genes just in general with hereditary cancer syndromes has increased a lot. And then I just wanted to briefly go over 2 studies that kind of show the impact of multi-gene panel testing. So this first study was specifically looking at people that have what we call adenomatous polyposis, or people that have a number of those type of colon polyps called tubular adenomas, which are a precancerous type of polyp, and we're seeing them develop more polyps than the general population. So in the top here, this is looking at people who have had 10 to 19 tubular adenomas. And then the bottom are people that have had over 20 of those polyps up to 99. And on the left-hand side, it is listing the number of people or the percentage of people that tested positive for a gene mutation when we were only looking at 2 genes related to polyposis. So only looking at that APC gene and the MUTYH gene. Whereas over on the right-hand side, this is showing the percentage of people that are found to have a mutation when we actually looked at 14 to 17 genes related to polyps and colon cancer. So we expanded the number of genes that were looked at, but it was still focused on genes related to colon cancer. And you can see that there's an increase in the percentage of individuals that are found to have a gene mutation. So there's an increase in the number of people that we identified, or that were identified to have a hereditary cause to their colon polyp. You can also see we more commonly find mutations in individuals that are younger when it comes to colon polyps, similar to if people have colon cancer at a younger age. But by identifying that cause for additional people, it gives us more information on how best to take care of them, but it can also give us that information for family members so that they may know if they could be at risk. Then this other paper was looking at multi-gene panel testing, specifically in individuals with young-onset colorectal cancer. So those with colorectal cancer before the age of 50. And in this study, all individuals underwent a genetic testing panel with 25 genes, and it did not include genes only related to colon cancer. It also included genes related to other types of cancer. And in this, they found that about 16% of individuals had at least one hereditary cancer syndrome. So they were found to have at least one gene mutation that they were born with that put them at an increased risk of cancer. But of note, a third of those found to have a gene mutation had a mutation in a gene that they did not meet genetic testing criteria for. So basically what this means is that they were found to have a gene mutation in a gene that doesn't quite fit their family history or their personal history. So if we were doing that testing like we did before 2013, it would have been a gene that we weren't too concerned about and we wouldn't have been testing. But because we have expanded our testing to look at genes related to other types of cancer, we can sometimes have these, what we kind of refer to as incidental findings. So findings we weren't quite expecting, but knowing about these mutations in the family then allows people to get the proper cancer screenings. So for instance, in some of these families, we did find a hereditary breast cancer risk. So it let us know, if people needed to increase breast cancer screenings or other types of care. So going through this, there are benefits and limitations to doing multi-gene panel testing. So one of the benefits, that we talked about is that increased mutation positive rate. So we are seeing more mutations for people when we do the larger panel testing, which can lead to getting more answers for families. And we are identifying those conditions that we may not have been suspicious of. So that's more so incidental findings, which, let us know about cancer risks that we may not have known about unless we had done this larger panel test. These larger panel testing is also cost effective. So we have found over time that with the new technology, it is it's more cost effective to test this large number of genes at one time instead of doing just a few at a time. But there are some drawbacks and limitations to this. So one is when we are looking at a larger number of genes, the more genes we look at, the higher the chance is that we find a variant of uncertain significance, or a VUS. And basically, this is a change in a gene that we just haven't seen enough times to know if it's truly a mutation that increases cancer risks, or if it's just a normal variation that we have in our gene. What we do know is that over 90% of the time, these variants of uncertain significance end up being just a normal variation or nothing. But it takes time for us to get to that point and get that answer. So it can be hard to sometimes have this uncertainty with a variant of uncertain significance. Even though we treat it as a negative result, it's still something that kind of just hangs out there that we don't know about fully yet. And additionally, we can identify mutations in genes or conditions that we have limited information on. So again, we might not have as much information about these gene mutations and the cancer risks with them, and how best to take care of someone with one of these gene mutations, which is where places like the Weiss Center comes in to try and get these answers. But it can be hard to live with one of these conditions that we may not know as much about at this point. And while I have it listed as a benefit of identifying these genes for conditions that we may not have been suspicious of with family history, this can also be a limitation. Some individuals do not want to know if they may be at increased risk for other cancer outside of the ones that they've been seen in the family. So that's where multi-gene panel testing may not be the right choice for everyone. But one of the big questions that we often get is, should I consider additional genetic testing? So what I'm going to do is just kind of go through 3 pretty common scenarios that we may encounter. Everyone's journey with genetic testing and when it was done and family history is different. So I can't go over every single scenario in this talk, but I thought I would highlight some of the main ones. So the first scenario is you previously underwent that single site mutation analysis for the known gene mutation in your family. And you're wondering, do I need to get any additional genetic testing? And regardless of whether you are positive or negative for that mutation, we generally start to consider multi-gene panel testing if you or a family member has been diagnosed with a cancer that has not been explained by the gene mutation in the family. But this also really depends on what the type of cancer is, as not all types of cancer tend to have a hereditary cause to them. But this is when we start to think about other genes. So, it's always good to ask your doctor if, there are things not necessarily fitting with the history in the family that you may need to be tested for. The next scenario is you previously underwent genetic testing but only had a few genes looked at, and you were not found to have any mutations in those genes. So this is the group of patients that we do recommend coming back for additional testing. So especially if you are in that group that had genetic testing prior to 2013, where your genetic testing only included maybe a handful of genes, this is when we do recommend coming back to consider multi-gene panel testing. Insurance companies tend to want to cover this type, but it really depends on your particular situation, which your genetic counselor can discuss in detail with you at an appointment. But this is definitely the group where we are most often consider doing that multi-gene panel testing. Then kind of the third scenario is you have undergone multi-gene panel testing within the last few years that has been negative for a gene mutation. And this is the group of patients that we don't have as straightforward of an answer because, even from just 2016 to now, we have identified a few additional genes related to colon cancer and colon polyps, but also other types of cancer. But a lot of those that have been identified are ones that it is much less common to have a mutation in those genes. So the likelihood that we would find anything additional is fairly low. And unfortunately, insurance companies don't like to cover multiple rounds of multi-gene panel testing. So it can be hard for this group of people to get insurance coverage for additional testing, which, is an unfortunate reality of, insurance dictating some care. So this is the group that we really want you to discuss with your doctor or contact your genetic counselor if there are any further genes that they think should be tested. And then kind of segueing from, you do genetic testing and get your test results back, just kind of going over the importance of why we want you to share your results with your family members and why it's important to also share the cancer history in the family. So first we'll start with those individuals that have undergone genetic testing and have a positive result. So they were found to have a mutation in a gene and have a hereditary cancer syndrome. So we recommend that you share your results with family members as it informs family members that they are at risk for the same hereditary cancer syndrome and lets them know that they should consider genetic testing. And the reasons why people like to consider genetic testing is, when we identify a hereditary cancer syndrome, it does lead to earlier and more frequent cancer screenings. With some of these conditions, we consider preventative surgery, such as removal of the uterus or the ovaries to prevent cancer. And also, knowledge of a hereditary cancer syndrome in a family also sometimes impacts individuals' reproductive decisions. So we do recommend that you share results with family members so they can make that decision about if they want to be tested for the hereditary cancer syndrome in the family. And really the number one way to know if they need testing is to know if this is in the family. And I just wanted to highlight that it is very important to share a physical copy of your genetic test report with family members. And the reason for this is on your genetic test report, it lists out the gene of what is causing the hereditary cancer syndrome in the family. And it also lists basically the address of where the mutation is in the gene or what page of the book to find the mutation. So that then allows labs to know exactly where to look to do the testing and get, a yes or no answer of if that mutation is there. On the flip side, it is also important to share your negative genetic test results with family members. And the reasons for this is it can still help clarify family members' cancer risks. So if, say, you are someone that has young onset colorectal cancer, and there's not really any other cancer history in the family, if you undergo genetic testing that is negative, we were not able to find a hereditary cause to your cancer. And so that lets us know that at that point, other family members do not need to undergo genetic testing. And it gives us an idea that family members are still at an increased risk for colorectal cancer, but not necessarily other types of cancer like we see when there is a hereditary cancer risk. And this segues into why it's important to share your history of colorectal cancer or colon polyps with family members. And that's because we know that having a close relative with a history of colorectal cancer, so having a parent, a sibling, or a child with colorectal cancer, does increase your lifetime risk of colorectal cancer from about 5% to 10 to 15%. So, informing family members of the history of colon cancer lets them know what their lifetime risk of colon cancer may be. And this can help determine what age they should start their colon cancer screenings, how often they should get them, but also what type of colorectal cancer screening is best for them. So, it lets them know that, maybe they should be undergoing colonoscopy rather than doing something like Cologuard because there is a family history putting them at an increased risk for colon cancer. And currently our guidelines is that if you have that first degree relative with colon cancer, so a parent, a sibling, or a child, that we start colonoscopies at age 40 or 10 years before the earliest diagnosis of colorectal cancer in the family. So say you were diagnosed with colorectal cancer at age 40, your children would then be recommended to start at age 30, so 10 years before your diagnosis. And for this group, we do recommend that the colonoscopy be repeated every 5 years or potentially more frequently based off of what is found on the colonoscopy. When it comes to families or individuals that have lots of colon polyps that we may not have found a hereditary cause to them, it's still important for your family members to know that there is a history of colon polyps, and really talk to your doctor about what age your family member should begin colonoscopies and how often they would recommend them to be repeated. And, we recognize that talking about your cancer history and also talking about hereditary cancer syndrome in your family is very hard. And it brings up a lot of hard feelings and can impact family dynamics. So we are always here to help. You can always reach out to your genetic counselor of how best to talk about this with family members and how to inform them about your genetic test results. We often provide letters that you can share with family members that has information about the hereditary cancer syndrome in the family and how to undergo testing. But we're also here to just talk through how to have this conversation. And if you are a former patient of Brandy Leach, I'm always happy to meet with you since she has moved on to another job at this point. Another great resource is Dr. Karen Hurley, who we mentioned a little bit earlier. She is a psychologist here who specializes in talking to individuals with hereditary cancer syndrome. So she's also another great resource to talk through how best to communicate this information with family members and sorting through all of the emotions that come along with that. And additionally, if you have family members that may not live in the state of Ohio or may be further away, another great resource is findageneticcounselor.com. This is basically a database where you can search by state to find genetic counselors and even specify, counselors that specialize in cancer to help family members identify someone that they can speak to near them. So that's all I had today. Thank you.
So thank you once again for joining us today. In the next 10 to 15 minutes, I plan to review the role of medications in preventing or delaying polyp and cancer in patients who have an inherited GI condition. This is something we refer to in the medical literature as chemoprevention. So this is the outline of my talk. First, I will describe some of the basic principle of chemoprevention. We will review some of the most commonly used medication, and some of you might be on these medications now. And then I will end the talk with some novel agents, some either medications or strategies that we're currently looking at and studying to see if they will have any impact on reducing or delaying cancer in our Lynch patients and FAP patients. So what is chemoprevention? As I said earlier, it's the use of a medication or a supplement to stop cancer from happening. Ideally, a chemopreventative agent should be effective, should be not toxic, and very well tolerated by patients. This is most often used in patients who have a high risk of cancer. And the reason behind that is we want to try to halt the process at some point. Most of the chemoprevention trials have been done on FAP patients, but not all of them. The reason FAP is an ideal setup to look at the effectiveness of a drug is that the cancer is often preceded by precancerous lesions, by polyps that take several years to grow and then eventually turn into cancer. This is a picture that Dr. Sommovilla showed earlier in his talk, similar to it. And this long adenoma polyp to cancer growth allows us to apply an intervention at one point, measure polyp count and size before the intervention and then after the intervention, so we can compare and see if our intervention was in any way effective. One of the most common medications studied were non-steroidal anti-inflammatory medications, also called NSAIDs. The way they work is by blocking one of the pathways called COX pathway or cyclooxygenase pathway, which is a pathway involved in cell multiplication, uncontrolled cell growth, tumor progression, and vessel proliferation. So the theory behind this is if we block this path, we may be able to blunt the process and delay cancer formation. Of the medicine that we looked at in this category are aspirin, Solandac, and celecoxib, also known as Celebrex. Aspirin has been widely studied in Lynch and in FAP. And I'm starting off with Lynch because this is a landmark trial that has changed our practice now in Lynch syndrome patients. So this is a large study that was started in the late 1990s, where close to 900 Lynch syndrome patients were randomly given either 600 milligrams of aspirin, so 2 adult doses of aspirin, or a placebo, which was a starch at the time. And the intervention was done for over a 24-month period. At the end of the treatment, the authors looked at the occurrence of colon cancer in each group. They did not find initially any difference in between the two groups. However, when observation continued over 10 to 20 years now, we have seen a different effect. So if you follow the line in red represent the Lynch patients who went on the 600 milligram aspirin a day, and the line in blue represent the patients who did not go on the intervention. 5 years into the study, those two lines separated, and the patients who were on high-dose aspirin, the line red, has significantly less incidence of colon cancer over time, and that reduction in risk persisted over up to 20 years now. The graph on the bottom shows all Lynch syndrome, the effect of aspirin on all Lynch syndrome cancers, not only colon cancer. And once again, 5 years into that intervention, we've seen a difference in between those who went on the aspirin with some protective effect, not as significant as what we've seen with colon cancer, but definitely the curves are separated. Now, in this trial, patients who went on the high-dose aspirin did as well as those who went on the placebo. However, we are always concerned with using such a high dose of aspirin because of the risk of GI bleed, the risk of brain bleed. So the question, would lower doses of aspirin help or have the same protective effect, came into play when this study results came out. And the same author actually now concluded the recruitment for another trial called the CAP3 trial, looking at comparing 3 different dosages of aspirin: the baby dose aspirin, 100 milligram, an adult dose aspirin versus the 2 adult aspirin. And at this point, we will need a few years to get those results back. But what the gold standard has been, or the standard of care for Lynch syndrome patients, is to at least have them started on an aspirin, ideally with a baby dose to start with, and the dose can be titrated down the road depending on how they do with the medication, how they tolerate the medication. Contrary to Lynch syndrome, patients with FAP did not respond much to aspirin, possibly to different behavior, different biology of the polyp and the tumor. But the CAP1 trial looked at the same dose of aspirin, 600 milligram, in about close to 200 children and young adults with FAP. At 1 year, there was no change in the polyp size or number in the rectosigmoid. And moving on to Sulindac, which is in FAP the most commonly studied medications so far. Sulindac is a non-steroidal anti-inflammatory medication, and has been shown, and this is a really old study, this is one of the first trial that was done, comparing Sulindac 150 milligram twice a day to placebo on a small group, 22 patients with FAP. And the graph nicely show you what change in polyp number and size happened over the course of the 9 months of treatment. So 3 months into the treatment, the number of polyp went down, the size of polyp went down. A peak effect was seen at 6 months into the intervention, persisted throughout the duration of the treatment up to 9 months. And then 3 months after discontinuation of Sulindac, polyp size and number went back up again. Sulindac was also studied in upper GI polyps, which is commonly seen in FAP. This is a small study of 24 patients who had advanced polyps, so large size polyp or aggressive polyps in the small bowel. When they were randomly assigned Sulindac versus placebo, videos were taken before intervention, after intervention. It was not thought to make any difference in the polyp burden or size. At this point, Sulindac is used as an adjunct to endoscopy in patients with FAP to help reduce colorectal polyp burden, as an attempt while we're attempting to delay surgery or as a bridge for surgery. The third anti-inflammatory medications that was also studied and previously prescribed, not so much lately, is Celebrex or celecoxib. This is a trial that looked at a high dose of celecoxib, 400 milligram twice a day, comparing it to a lower dose, 100 milligram twice a day, and placebo. And same thing, we looked at the change in polyp number and polyp size over the course of the treatment, which was a 6-month study. We found a significant reduction in polyp size and number with this high dose of Celebrex. In this study, side effects or adverse events were similar among all 3 groups. Celebrex was also looked at in terms of upper GI prevention or delaying polyp progression in the duodenum, in the small bowel. And similarly, higher dose Celebrex, 400 twice a day, had the greatest impact on reducing polyp size and burden over the study period. After the study, which is close to 2000, the FDA approved celecoxib as a chemopreventative agent in FAP as an adjunct to endoscopy to reduce colorectal polyp burden. However, in 2011, the sponsor of the study withdrew this indication as they failed to provide post-marketing analysis, which was mandated by the FDA. So Celebrex may be used in patients. We often use, we may use it, I should say, for upper GI polyps, like advanced duodenal polyposis, while trying to delay surgery as much as we can. Side effects includes risk of GI bleeding and brain bleed. So you'll have to discuss the side effects and the safety profile of the medications before going on such a treatment. Now, the interesting part is the novel agents, those newer agents that we are currently studying now, and some we will be starting our studies in the next few upcoming months. So the rapamycin and FAP, maybe some of you might be on this trial already. It's a phase 2 trial. We're looking at a new agent called rapamycin, which, different than NSAIDs, work on a different pathway called the mTOR pathway. So it's a fancy name. It's a pathway that is involved in tumor progression. The idea here is if we block that pathway, we might be able to halt tumor progression. So who could be in this trial? FAP patients who are older than age 18, who have more than 10 rectal polyps may be enrolled in the study. The study is looking at the safety of rapamycin, but as well as its efficacy in terms of reduction in colorectal polyps and also duodenal or upper GI polyps. In the next few months, we will be starting our obeticholic acid trial, OCA. OCA is a drug that is similar to bile acid. It's typically produced by the liver. OCA is known in studies to reduce inflammation and fibrosis, scar tissue. We know that it binds to a receptor in the lining of the intestine, which potentially could have a positive effect on preventing cancer. We don't know whether OCA will work in reducing polyps and FAP, but it's and this is what the purpose of the study is, to look at the safety of OCA, a daily dose of obeticholic acid, as well as its efficacy in terms of rectal polyp and duodenal polyp. The exciting news for our Lynch patients is the first ever Lynch vaccine trial. And we are very excited that our center would be one of the center involved in the Lynch vaccine trial. So the idea here is that in Lynch syndrome, as was mentioned earlier, there's an accumulation of genetic errors inside the cells. And these errors in the genes will eventually lead to production of new proteins called neoantigen. These new proteins are shown here in blue, get expressed on the tumor cells. The tumor cells is represented here by the blue cell. So these neoantigen are considered strangers proteins, so new to the human body, and they could drive the body's immune system to come recognize them and fight them, eventually lead to killing of that tumor cell. The immune system is represented in this picture with the red cell. So anytime we can enhance our immune system to recognize these early protein and kill these cells before they progress and grow. The concept of the Lynch vaccine trial is not new. It has been looked at and studied and done in cancers induced by viruses, such as hepatitis B. So there's vaccine against hepatitis B, which is known to trigger liver cancer. And another example is the HPV vaccine, which is also known to trigger cervical cancer. But this Lynch vaccine trial is the first one that looks at preventing non-virus induced cancers. So the trial will consist of 3 injections containing precancers or cancer cells or protein. And the goal is to get the immune system to recognize these precancerous proteins and develop an immunity against these cancers, so that next time they're exposed to these proteins, the immune system will be up and ready to fight and kill these cells. Who may be able to participate in the Lynch vaccine trial? So all our Lynch patients who have MLH1, MSH2, EpCAM, or MSH6 gene mutation and at least 1 adenoma, or our PMS2 patients who have a history of colon cancer, but no active cancers allowed within 6 months of this study. We will be having updates on the timeline of this study and when it will start. And we are very excited to have our patients participate to help guide us and close the gap in knowledge. So a few key takeaways from this talk is that chemo prevention helps blunt polyp burden and progression. It does have a role in delaying cancer progression in FAP and in Lynch syndrome, but it does not replace endoscopy or surgery, which are the mainstay in treatment for these conditions. We have several novel agents that are currently under investigation, a lot of opportunities for research for our patients to participate in and help us define the role of these strategies in reducing cancer risk. Well, thank you for listening, and I am happy to take any question at the end.
I'm one of the GI oncologists, and we'll be discussing today some updates about management of systemic treatment in the setting of surgical resection for colorectal cancer. So next, please. I don't have any disclosures. Next. Next, please. Okay, so the outline is of what we do today. I'm gonna do a brief introduction of how do we manage colon and rectal cancer at diagnosis. I will focus on early stages, so no discussion of metastatic disease. We'll talk a little bit about some new data about immunotherapy in the setting of colon and rectal cancer, specifically in the deficient mismatch repair that include patients with Lynch syndrome, and also evolving role of circulating tumor DNA or ctDNA. Next, please. Just as a brief introduction to staging of colorectal cancer, if we have a tumor that is penetrating through different levels of the colon wall, this would be usually considered stage 1 or 2, depending on how deep it penetrates. If there are any lymph nodes that are involved, then this will make this a stage 3. And once the cancer goes outside of the colon region, for instance, to other organs such as the liver or the lung, then it becomes a stage 4. So we will focus today on stage 1, 2, and 3. Next, please. A couple of notes about staging. Oftentimes, people ask about whether whether there is a change in the stage of their cancer. We often look at the stage of cancer is what is initially staged. So there are certain instances, for instance, in rectal cancer, where we have a clinical stage based on imaging, and we provide treatment, and upon surgery or after treatment, we see that the cancer changes. We may start with a stage 3 and it becomes a stage 1, for instance, afterwards. That is a change in stage in relation to treatment. If a cancer recurs, it doesn't become a stage 4, although people like to refer to it as that, but it becomes a recurrent, whether locally recurrent or distally recurrent. The staging for both colon and rectal cancer is the same when we look at the prior image that I showed. But there are differences in that for colon cancer, the proper stage can only be done after surgery. In rectal cancer, because it's located in the pelvis and surrounded by soft tissue, we do have the advantage of several testing methods that can allow us to, with good accuracy, know what the stage of it is, whether it is stage 1, 2, or 3. We can use MRIs, we can use sometimes endorectal ultrasounds if MRIs are not available. And the important thing about the staging is that stage usually determines what type of treatment we offer either in the beginning or after surgery. Next, please. A couple of words about colorectal cancer in a younger population, less than 50 years old. As you can see that there is a higher rate of hereditary syndromes that could be detected in those who are under 50, which is why, as you heard earlier, we'd like to have anyone who gets diagnosed at a younger age be seen and assessed by a genetic counselor and optimally tested. The risk of developing colorectal cancer depends on the underlying syndrome, and it could be anywhere from 20% to 100% in a lifetime of a person who carries such mutations. The other concerning fact is that for both incidence and mortality in a younger population, these have been rising gradually over the past few decades. And a lot of this is based on increase in rise in the incidence of rectal cancer too. Next slide, please. So we're gonna try and go in a kind of a simplified way. How do we manage these tumors? For colon cancer, if we do a resection and then it is a stage 1, which means that it has penetrated just into the muscular layer of the colon, but not through it. Oftentimes surgery is adequate and no need for adjuvant therapy. The survival for these patients is pretty good, more than 90% at 5 years. And they often will need to have a repeat colonoscopy at 1 year and then subsequently at different intervals based on the results of those colonoscopies. Same thing also applies for stage 2 and 3 in any resected colon cancer. We have to refer patients to undergo a colonoscopy for follow-up to make sure we pick any evolving polyps. Next slide, please. Now, stage 2 colon cancer, this is kind of a deeper penetration of the cancer through the colon wall. This becomes a little bit tricky to handle. And to simplify it, we can look at this at maybe a very low risk for recurrence. And those are the folks who have deficient mismatch repair tumors, such as those with Lynch syndrome. Of course, Lynch only accounts for about maybe a third of these cases, but the majority are just random and sporadic, what we call epigenetic changes that may happen because of changes to the DNAs called methylations. There are high risk patients with stage 2 and those who present with perforation or obstruction or who have penetration of the tumor through the whole thickness of the colon wall, maybe extending into other organs. Those who have low number of lymph node harvested during surgery, and those are at risk of being understaged, of course. And the average risk is those who have what we call a T3 or kind of a middle of the road penetration through the colon wall with minimal other or no other risk features. And this is the majority of stage 2 patients. Oftentimes for low risk, we know that if we give actually chemotherapy, the survival outcomes might be worse than not doing anything. So we absolutely do not recommend chemotherapy in these situations oftentimes. For those with high risk, we recommend chemotherapy, but we still don't know what is the added value of chemotherapy to not doing anything. And I mean, the best studies or best trials looking at adjuvant or post-operative chemotherapy, we can see that the benefit is less than 4% at 5 years survival. And those with average risk, oftentimes we do not recommend chemotherapy in setting after surgery, but it's a discussion. We discuss with the patient, we look at what the possible risks and the benefits from treatment. And this is where some of the new developments in ctDNA may come into play in the near future. And we'll talk a little bit about that later on. Next slide. Now for stage 3, these are the situations where lymph nodes are involved. We always recommend chemotherapy. Next. As you can see here, this is some of the earlier studies about 3 decades ago, where it shows that those who receive a chemotherapy called 5-FU did much better in terms of survival at 5 years or later on compared to those who had only surgery. But keep in mind that even those who had only surgery for stage 3, about 50% do not need chemotherapy, and they survive the cancer without any added chemotherapy. The next slide. This is from a mosaic study that was done in mid 2000s and updated. We can see that for stage 3 colon cancer, there is an added advantage to adding a drug called oxaliplatin to the prior drug we mentioned, 5-FU. And this adds about an absolute 5% improvement in survival over 5 years. So this becomes a standard of treatment for those with stage 3 colon cancer. But the regimen, as it was originally started, was for 6 months. And because of that, there is an increased risk of peripheral neuropathy, which is a common side effect of oxaliplatin. Next slide. This led to a multi-arm international study called the IDEA study that looked at the fact, looked at basically whether 3 months of chemotherapy was any worse or equivalent to just doing 6 months of chemotherapy. And as you can see in the top figure, the curves are almost identical. So our current standard right now is 3 months of chemotherapy after surgery for those who have stage 3 colon cancer. The bottom graph actually looks at a bit of a differentiation in those who are under 50 and those who are over 50 years. And you can see that for the earlier or actually let's say stage 2, a high risk stage 2, or a better risk stage 3, those who are over 50 or under 50, they did the same, or in the case of high risk stage 2, those who are under 50 did a little bit better. But when it becomes a little bit more aggressive in terms of the staging, so those who have stage 3C, those who are under 50 did a little worse than those who are above 50, and brings a question whether there's need to be a different approach or perhaps a different length of therapy or a more aggressive therapy than what we currently use. Next slide. And a few words about the rectal cancer. Generally speaking, and this is oversimplification, but those who have very early stage rectal cancer, oftentimes they undergo surgery. Those who have clinical stage 2 or 3, it used to be that we do chemoradiation, we follow that by surgical resection and then more chemotherapy. But a few years back, we were part of a study that looked at an approach called total neoadjuvant therapy, or TNT for short. And that included either going through chemotherapy plus radiation followed by chemotherapy consolidation, or the opposite. So starting with induction chemotherapy and then following that with chemoradiation. And those who had complete response, we just observe over time, and those who did not have a complete response will undergo surgery. It turns out that eventually about 50–60% of who undergo the chemoradiation first, followed by chemotherapy, could have organ preservation and did not need to have any surgery afterwards. And this is important for low-lying rectal cancers because oftentimes the surgery for that would be what we call an abdominal perineal resection, and will leave patients with a permanent colostomy. So this is a colostomy saving approach. If you show the next slide. This is the surgery-free survival from the study I just mentioned, and the red line is those who had chemoradiation followed by chemotherapy, and you can see that more of those did not need to have surgery eventually and did very well. Let's go over the next slide. staying on the topic of rectal cancer, I want to just share the information that we had presented. Actually, Dr. Sosek from Memorial Sloan Kettering. This made the news actually internationally with a break-in abstract and presentation at the Oncology National Conference in ASCO earlier this year. They so far have enrolled actually 18 patients, but not all of them had a very long follow-up. But half of those had the Germline-Lynch syndrome, and 6 out of these 16 were under 50 years. What they did is that they looked at rectal cancer patients who had deficient mismatch repair. So deficient mismatch repair, these are genes responsible for making proteins or coding proteins that are that help with repairing DNA transcription errors. And if they are deficient, they increase the chance of colon cancer. And they also are known to respond well to immunotherapy. We have data for that in the metastatic setting. So they looked at, instead of doing the chemoradiation and chemotherapy, what if we just tried chemotherapy? So you use this drug called dostarlimab, which is already approved for advanced cancers with deficient mismatch repair in any type of cancer. And they gave this to the patient every 3 weeks for a total of 6 months. And then at the end of that, if they did not have any complete response, they would go with chemoradiation and then maybe surgery if need to. They had rigorous assessment with like what we do for initial operative approach. So they had endoscopies and biopsies at 6 weeks, 12 weeks, and 24 weeks, and then also MRIs of the pelvis, scans of the chest, abdomen, and pelvis, and a PET scan at 3 months and 6 months. Next slide, please. So this was the most important slide of the presentation because each line of these represents a patient, and the yellow dot line or the orange dot line is at the time of clinical complete response. So I could see, as you could see, for all of those patients who at least made it to the 6-month follow-up, all of those had a complete response. So no evidence of cancer by scopes, biopsies, PET scans, or MRIs. The study is still ongoing. Of course, this is not yet a standard of care, but it does bring up a question of whether this would be in the near future. Next slide, please. How about colon cancer? Can we do the same thing for colon cancer? There actually is a Dutch study that looked at the same thing for those who have clinical stage 2 or 3 by scans and deficient mismatch repair. They were treated with two treatments only of immunotherapy. The first one was a combination of nivolumab and ipilimumab, and the second one with nivolumab 2 weeks later. And then within 6 weeks of starting this treatment, they would have surgery. Most of these patients had really bulky tumors that have extended either into other organs or lymph node positive disease, at least based on scans. All of these patients had surgery eventually, and more than 95% had it within 6 weeks. Next slide, please. So again, this is called the waterfall plot, and each line of these is an individual patient. And you can see that about 2/3 of these patients who treated with only 2 doses of immunotherapy had complete response with no evidence of disease by the time that they had surgery. And the majority, actually more than 95%, had a major response described as more than 50% reduction in cancer size by the time that they had surgery. So this again is not a standard, but it is very important data to look at, and it may change how we treat these patients either in the preoperative setting or even in the postoperative setting, because there hasn't been any recurrences even for a short follow-up. even though many of those patients did not have any adjuvant chemotherapy afterwards. Next slide, please. I will spend a few more slides talking about ctDNA. This is also referred to as liquid biopsies. So think about the blood for those who have cancer as have different elements besides the typical stuff that you see in blood, and that includes free cell-free DNA, which is DNA without any cells. There are also circulating tumor cells, and there's also circulating tumor DNAs, and we can identify those by the changes to this DNA fragments called through methylation, for instance. There are two types that we can do in earlier colon cancer. The first is tumor-informed, meaning that they match the cancer DNA from a biopsy to the DNA in the plasma, and the other one is non-tumor informed or plasma only, and looking at these methylation changes in the DNA. And these serve two purposes. They can serve a purpose for predicting and maybe prognosticating for treatment and the responses after or maybe outcome after surgery. And the other thing is for early detection. And we know that these tests can detect cancer recurrences maybe 3 to 6 months before they can be visible on CT scans. The problem is that we don't know what to do with this information yet, so I'm not going to spend too much time on this right now. Next slide, please. We know that ctDNA can be very prognostic. So for those who have surgery and they have positive ctDNA a month after surgery, these are 7 times more likely to have a recurrence of the cancer. And for those who have adjuvant chemotherapy and they still have a positive ctDNA, they almost have a guaranteed chance of the cancer coming back. As you can see here in the orange line, the blue line are those who have ctDNA that are negative after surgery or after chemotherapy. Next slide, please. We also know that it can be a marker of response to chemotherapy. The rate of conversion from positive ctDNA to a negative ctDNA is about 25 to 68%, depending on the studies that you look at. And if we're able to do that conversion from positive to negative, or if you look at the left-hand table, if someone was negative and then converted to positive, anyone who has a either remains negative or converts to negative with treatment or spontaneously, they have a very good chance of not having a cancer recurrence. But those who remain positive or maybe convert from negative to positive, they have a high chance of almost 60% of having cancer recurrence, and even earlier through the course. Next slide. There are many ongoing trials that are looking at utilizing this. Many are looking at stage 2, specifically low and high risk, and also, or let's say average risk and high risk for stage 3 clinical studies. And many of these are looking at a couple of things. First of all, whether escalation of treatment after surgery can be beneficial. For instance, if you use more aggressive chemotherapy for those who have positive ctDNA, or can we avoid using chemotherapy and avoid side effects in those who have negative ctDNA, even if they had stage 2 or stage 3 cancer? Next slide. One of these studies is a COBRA study. We are participating in this here, and this is for average risk stage 2. Stage 2 colon cancer. Those who have ctDNA that are tested and they are positive, and this will be the 10 to 15% of those who get the surgery, they will be assigned to chemotherapy for 6 months. If they had negative ctDNA, then they would just undergo surveillance, and then we'll see whether we can be a little bit smarter about detecting who can benefit from chemotherapy. We also have another study that will be opening soon, looking at tumor-informed DNA for rectal cancer and see if there's any correlation between that and responses to treatment on the TNT protocol previously mentioned. Next slide. So in summary, colorectal cancer incidence and mortality in younger population is on the rise. Adjuvant chemotherapy after resection benefits some people, but we also overtreat many to get that benefit in some. ctDNA has the potential to influence our choices and become a little bit smarter about who should get it. Can we avoid giving chemotherapy to some? Can we optimize the regimen and how long we might need to treat? And immunotherapy may emerge as a first-line option for those with deficient mismatch repair in colon and rectal cancer.
We do have several questions in the chat that I'll go through in order, and I ask our panelists to unmute themselves and come back on the video. So I think we'll start with you, Sarah. So from a preventative standpoint, could you talk a little bit about some of the Lynch syndrome screening guidelines for some of the less common Lynch cancers that we see? Those mentioned are pancreatic, brain, breast, etc. We talked a little bit earlier about urinary tract cancers and the fact that we've kind of changed from doing routine urinalysis to doing tests based off of patient symptoms or family histories. But could you talk about some of those other conditions?
Yeah, so a lot of those also go back to family history. So at this point, we only recommend pancreatic cancer screenings for those that have had a close relative with pancreatic cancer who have Lynch syndrome. So like a sibling or a parent, or even a child. And those typically start around age 50 or 10 years before that pancreatic cancer diagnosis. And this can sometimes be with MRI or a specialized upper endoscopy that also uses an ultrasound. As far as breast cancer risks with Lynch syndrome go, we don't know if there is a true increased risk of breast cancer with Lynch syndrome. So again, we fall back to family history. So it really depends on, reproductive factors plus family history of if there are individuals with young breast cancer in the family, of if additional screening is recommended. And usually if there's additional screening, it would be breast MRIs. As far as brain cancer goes with Lynch syndrome, we typically don't do any kind of regular brain cancer screenings, but we do recommend that your doctor does a neurological exam every year to look for any changes in your neurological status that may, lead us to do some additional imaging.
Unfortunately, one of the problems with things like brain cancer or pancreatic cancer is that they often don't present with symptoms until they're pretty advanced. So pancreatic cancer, some of the early symptoms can be bloating or nonspecific abdominal discomfort, or sometimes developing jaundice or yellow discoloration of the skin. And similarly, brain tumors, when they develop, usually present with neurologic symptoms, so things like stroke-like symptoms or possibly a seizure. Moving on to the next question. Have there been any studies on whether the increased number of surgeries has any impact on the development of desmoids? I'll address this and invite Dr. Liska, if he's on, can also comment on it. We do know that desmoids do tend to develop after surgery. Most desmoids don't develop before surgery, although some patients at very high risk of desmoid disease will develop them without having any surgeries. And Dr. Anderson mentioned earlier some of the studies that we've done to look at whether the type of surgery might impact desmoid development. We don't know for sure that more surgeries creates additional desmoid risk. We don't know, for example, whether patients with 3 surgeries will have more risk of desmoid than 2 surgeries. It does make sense to think that with each additional surgery, there is probably additional desmoid risk, though we don't definitively know the answer to that question.
Yeah, I agree with what Dr. Sommovilla said. When we think about desmoids, they are formed by fibroblasts. Fibroblasts are a certain cell type that is very important in scar formation. So that's why we understand why surgery can lead to desmoids, because whenever you do surgery, there is scarring that occurs, and in FAP patients, they're just at a higher risk for the scar formation to go awry and for these desmoids to form. So it makes sense that more surgery increases the risk for desmoids, and that is something we do see. And like Dr. Sommovilla said, also the type of surgery can influence how high the risk for desmoids is. And we know that desmoids can, in FAP patients, most commonly occur in the abdomen, either in the mesentery, which is where the blood vessels to the intestines go, or in the abdominal wall. And we often do see that these desmoids form in the abdominal wall at the site of incision. So yes, we are worried about surgeries causing, leading to more desmoid formation, which is why we try to avoid surgery in FAP patients that are at risk for desmoids if we can avoid it.
And just to touch on the second question about a roadmap of research, one thing that we've discussed with some other centers is the possibility of doing a clinical trial to see if any of the medications that we use to treat desmoid disease might be able to be used after a patient has surgery for FAP, usually a colon surgery, to see if that might lower the risk of developing desmoids. But that's something that's probably going to take a long time to organize a trial for and get results for. Sarah, maybe you can address this next question. As a precursor to having multi-gene panel testing, is it effective to get DNA testing via Ancestry.com, 23andMe, or one of the other testing services that's available commercially?
Yeah, so the way that testing is done with what we call direct consumer testing, so tests like 23andMe or Ancestry that you can do at home, the way the testing is done is very different from the way that we do testing in clinic. And the test that's done by like Ancestry and 23andMe, they're looking at markers for ancestry and some markers for diseases, but they're not looking in depth at these genes related to hereditary cancer syndromes. You'll sometimes see them advertise that they report on gene mutations in BRCA1 and BRCA2, but they actually can only report on 3 specific mutations when actually hundreds of them exist in these genes. So those types of at-home tests would not give you the same full picture that clinical testing does. And even if you download your raw data from one of these sites and upload it to another party that says that they will analyze for other health conditions, just the way the testing is done in the first place, it doesn't really translate to looking for all of these other health factors. And we have seen that, when someone downloads their raw data and uploads it to this other site, a lot of the time the results that come back from that tend to not be necessarily correct when we do clinical grade testing. So we really, recommend talking to somebody about that clinical grade testing, as that is actually going to give us a full picture of these genes with hereditary cancer syndromes.
Great, thank you. Dr. Macaron, you responded to this question in the chat about turmeric, but I was wondering if you could just comment briefly on patients who have sulfa allergies and what chemopreventative measures they might be able to take.
The chemo prevention is in FAP. We have a lot of agents that are now under study. So Sulindac and Celebrex are our early agents that we looked at and on whom we found some benefit. But I did also mention the trial with rapamycin, which is a completely different mechanism of action, looking at blocking a different pathway, the mTOR pathway, and on whom preliminary data from what we've seen is about like 30 to 40% reduction in polyp count and polyp size. So this is an avenue. Another avenue is the omega-3 fatty acids or the the OCA, obeticholic acid, that I also mentioned. It's still under research. It's a phase 2 trial looking at efficacy and safety of the medication in FAP patients. So that's another option that we have. Now, I do know of a cross-reactivity between Celebrex and sulfonamide agents, so that I understand. I'm not aware of a Solandac interaction with a sulfonamide component. So that remains an option. For turmeric and all other antioxidants, I know at one point we did a blackberry like suppository trial looking at those antioxidant properties of and vitamins in blackberries. And again, results are anecdotal, small studies, not consistent. Same thing as with turmeric, but it's a field like an ongoing research in the field. So we would like our patients to be involved in research and help us advance the knowledge.
And then Dr. Estfan, Dr. Liska had a question for you. What's the optimal adjuvant therapy regimen for a young Lynch syndrome patient with stage 3 colorectal cancer after surgery?
Yeah, thank you. That's a very good question. It's so the correct answer for that should be, consider a clinical trial. We do have a clinical trial going on right now in our regional satellites, where those who have deficient mismatch repair, so basically including Lynch syndrome, they have stage 3, then they either would be assigned to the standard treatment, which off trial it would be still chemotherapy, with oxaliplatin-based regimen, versus the same thing with the addition of immunotherapy. So that would be an option that we would refer people to. Off clinical trial, it would still be chemotherapy. The problem with immunotherapy is that in the adjuvant setting, we still don't know a whole lot. How would that translate into efficacy? For certain tumors that did not seem to work very well, like for instance, some studies in renal cell cancer, but in others like melanoma or maybe lung cancer, that there is benefit. So it's still yet to be seen. And we don't know whether just kind of moving to doing immunotherapy even before surgery would be the optimal thing to do. The data is very impressive, but again, it just with 2 doses. Should we treat for longer, for instance, than just for 2 weeks, or should we try different combinations and avoid chemotherapy altogether? These are all questions yet to be answered.
Great, thank you. Maybe just one last question that we could address real quickly, Sarah. So if a patient's tested for APC gene and that shows negative, would the result also show if someone has a mutation, or would they only be looking for the specific APC gene?
So we actually all have 2 copies of this APC gene in our body. And typically someone has 2 copies of this gene that is working regularly and helps with cell turnover in the colon and helps, prevent polyps and things like that from forming. But when we do genetic testing of the APC gene, we're actually looking at that gene and basically reading through the gene to see if there's any mutations or a change in the gene that is causing it not to work. So your genetic testing would have been looking through that APC gene for any mutations.
What you're going to be hearing today is a blend of my experience as a clinical psychologist of research, but also my experience of sitting in the room with many, many people who have confronted either living with cancer risk, with going through cancer treatment, or both.
Okay, so that's enough of my multitasking, and let's go to slideshow, and there we are. Yes. Some of you, so first of all, I just want to say I have no disclosures, and any photos that you see do not depict actual patients. So many of you actually may recognize the quote in my talk titled Thinking Fast and Slow as the best-selling book from 2011. The book is a summary of the work by Daniel Kahneman, who actually won a Nobel Prize for his work, along with other cognitive psychologists and economists over the years who have done research, probably dating back to the 80s and 70s, on how do people process numeric information, especially when it's expressed as a probability or a percentage. So there are lots of experiments that have been conducted on how people process risk information, what kinds of decisions they make, and how do they arrive at those decisions. So the core of the work in Thinking Fast and Slow is that research has shown that people take mental shortcuts when they're presented with percentages and probabilities that lead to estimates that are different than what is given to them, and in that sense are inaccurate estimates, so that people will act in ways that don't reflect the actual numeric probabilities or risks that they're presented with. So let me give you a non-cancer example just so that we're clear on what we're talking about. So this was an article from the New York Times in 2013 when one of the regional trains experienced an accident, and they interviewed someone who was present in the train car when it happens. He described his experience in terms of the sounds and that the train car actually rolled over, which obviously was a terrifying experience. So, but then let's look at what he said at the very end. You think that you're safe on a train. I know I'm going to be taking a car for a while to get to work. Now, of course, if we think about probabilities, the risks of dying in an automobile accident in the United States at that time were there were 34,000 deaths that year versus 451 deaths due to a train accident. But because this was such a vivid example and such a personal example of what can happen when you're in a train that experiences an accident, he was basing his decision about what to do about his risk of dying in any kind of accident based on the experience, not on these numbers. That's the core of the arguments that you will see in the book, Thinking Fast and Slow. So why are we interested in this phenomenon? Because cancer deals in many probabilities, and ones that are highly meaningful and that do require decisions. So you've been, wherever you are in your journey of dealing with colon cancer risk, you've heard numbers about your chances of inheriting a mutation, the chances that you'll experience various surgical outcomes, whether it's chance of infection afterwards, chances of what your bowel functioning will be like, and so forth. If you've been recommended to go through chemotherapy, you'll get estimates of what different kinds of outcomes you can expect, or what kinds of effects that you can expect. Again, all expressed in numbers. And then, of course, some of the numbers that can be the most threatening are the numbers that you get about your risk of getting a particular cancer, or if you've had cancer, what is your chance of getting a recurrence? or a different kind of cancer, depending on whether you have a hereditary syndrome. So why do we give you such a barrage of numbers at this important time when you're trying to make decisions? It's for two reasons. It's number one, all of the doctors that you've heard from today, are working really hard to make sure that we make recommendations that are based on scientific research and analysis, being able to garner knowledge that is based not just on our impressions or a case-by-case basis, but that rather brings together experience so that we can look at things objectively. Another thing that's extremely important is that the treatments that we offer are done on an ethical basis where you're informed about what might happen so that you are not, hopefully not blindsided by problems that might arise afterwards. And to have information about the expected effects and benefits that you might experience. The core issue that we need to address is that you're being told based on research and informed consent what is likely to happen, but still in translating from probabilities which are based on groups of people down to one person's individual experience, we can never promise which side of the numbers that you are going to fall on. And so that introduces a level of uncertainty that can heighten the chance that you might engage in some of the cognitive styles and the type of thinking that is described in Dr. Kahneman's book. So with that, let's start with think fast. So what does that mean? And I do want to say that I'm not going to be giving a book report on Dr. Kahneman's work. So rather, I may use the term somewhat differently than he does. So this is more inspired by his book rather than a strict reporting of how he conceptualizes things. That said, think fast is based on the characteristic shortcuts that people take especially in conditions of threat and uncertainty. So we've already seen one example of this form of shortcut or bias, which is the availability bias. So this is when the chances of something seems higher than they are because of a vivid example, such as, being in a train wreck. So things are, people will estimate their chances of something being higher than they are when there's an example that's either vivid or very easy to recall or easy to imagine if it's something you haven't been through personally. So let's take a look at a couple ways that operates. So this is an example from breast cancer, not colon cancer. But nonetheless, it shows an important point. So I also work with a lot of women who are making decisions whether to have bilateral mastectomies after a BRCA mutation. So there have been a number of articles over the years describing women who choose to have a bilateral mastectomy to deal with their risk. And you can see the headline in this one, this is taken from a London newspaper, A Mother's Diary of Her Brave Bid to Avert Cancer. So you can see it's very vivid. It stands out in that this is a dramatic choice, right? And so this leads, these types of articles lead women to think that there are more women out there choosing bilateral mastectomy than there actually are. For example, you don't see countering arguments that say someone's, brave choice to go get mammograms every 6 months. So the actual numbers are much lower than you might think based on the number of articles that are out there. Research shows that maybe only 20% of women will choose a bilateral mastectomy in the first 3 years of learning their genetic test results. That goes up pretty dramatically if they have cancer at the time they also get their gene results, but it's nowhere close to everybody, or nowhere close to 100%. Another thing that's much more personal is that the chances of experiencing some kind of outcome or disease are heightened by these intensely personal experiences of witnessing someone being ill, perhaps by being their caretaker, perhaps by cancer striking someone who's close to you, whether it's a family member or it's someone that you know, a neighbor or a friend. It can be especially shocking if they don't have a risk factor, or if they seem very healthy and have been doing all the right things. Someone who eats well, exercises a lot, and then gets cancer anyway. This can also make risk stand out and be very vivid. The other main mental shortcut that affects how we process cancer information is called misimagining. And there's two ways that this shows up, is that people can focus very specifically on a certain impact without considering what else might happen. And so if we take that out of psycho speak and put it into lay terms, it means that you think more about what you're not going to be able to do, say after a surgery. You won't be able to eat certain kinds of foods, but that there are many other parts of your life that you'll be able to carry on as normal. So part of the adjustment process turns out to be gradually being able to shift your focus from what you can't do to what you can. So people do tend to underestimate how they're going to feel about something if they haven't been through it, and they can't imagine learning to live with something if you have to. How many people have said to you, "Oh, you must be so brave to go through this." Well, if you're in the process of learning to live with colon cancer risk or colorectal cancer, it's not a question of you being brave. It's a question of resilience processes that you're finding within yourself that you didn't know were there. This is an illustration of that misimagining. When I first started working in this area, and I learned that some people have their entire colon removed as part of prevention or treatment, it seemed like science fiction to me. I didn't know that you could live without a colon, and you probably encounter many people in your life. If you're living with having had a subtotal or total colectomy, that the body does adapt physically, and that you have the potential to be able to live well without a colon. So let's shift gears for a moment, think slow. And this is a little bit where I diverge from Kahneman's model, is that what I'm talking about in terms of thinking slow is what happens during the crisis of learning a genetic or a cancer diagnosis. It can feel like you're in a dream. So people who've been through a tough diagnosis will describe experiences like, it feels like I was in a movie or in a fog. I just shut down. I felt numb. I felt like I had an out-of-body experience. So these are all things that happen due to a natural response to trauma and shock, which is, it's almost like a buffer. It's like a mental airbag that inflates to buffer you in a crisis. So just like an airbag, it's meant to help you in the short run, but it is not useful to keep it inflated, and you can't drive with an airbag in the long run. So what happens is, in that state of fog, if it persists, that it can actually increase the chances of experiencing things like post-traumatic stress or depression. So it's pretty common to have that experience of numbness and shock, but if it persists, that might be a sign of needing some professional help because the sense of shock is lingering. So there are lots of emotional challenges that can cause that kind of shock reaction. There is that initial reaction, having to cope with the abrupt changes that can happen during a diagnosis. There's a lot of waiting and worry, especially in that early time. And then people who've been through trauma in the past of some kind, even if it has nothing to do with cancer, may be more prone to having that shock reaction. So if we're going to find that medium, that middle way between fast and slow, what does thinking medium mean? So the core of sort of finding our way is to look at this conundrum that that cancer risk and cancer push forward into our consciousness, which is that the randomness of cancer does not make sense. Especially, it's hard to think that something so important as your well-being or the well-being of others you care about is subject to chance. And yet, at the same time, we search for meaning as people. We want our lives to make sense. We want things to have some sense of order. And so when you're presented with a string of letters and numbers on a page, meaning that, life is changing, trying to translate this into something that makes sense for the very personal decisions you have to make is the core of what we try to help you with at the Weiss Center. So, another way to look at the dilemma posed between fast and slow, that if thinking fast is a shortcut, are you actually making an informed decision? So kind of one of my tasks as a psychologist is sometimes if someone's in that think fast mode and is being strongly influenced by one vivid example that is crowding out some of the important numbers that should be taken into consideration in a medical decision, is to help the person slow down. But at the same time, do we consider in a view of numbers and a view of one's situation, if there's a strong emotional component, is that necessarily irrational? So in my experience, my way of explaining this is that decisions actually involve a balance where they have to make both cognitive sense and emotional sense, is that you need to collect all the relevant facts and understand them in context. And that includes understanding the emotional context and what that means for you, dealing with your feelings about having to make a decision and how this fits into other important parts of your life. And then the third component is not just learning the facts, but knowing what you're going to do with them, that you have knowledge, you have coping skills, and you have social support to carry out your decision. So the other important piece then in terms of thinking medium is to trust in resilience, that most people do adjust over time. And this is something that we do know from psychology research, not only in cancer, but many other kinds of stress. We also know from research that resilience is not some magical quality that some people have and some people don't, but it can be cultivated. Oops. All right. So I want to close with a vivid example, but this is a vivid example of the process of resilience. So a little while ago, I saw a woman who was in her 40s. She had FAP. She had been living pretty successfully post colectomy for a number of years, but then she started having blockages and needed a revision of her surgery, which meant that she was very likely going to wake up with a colostomy bag, which was very upsetting to her. And she said, just put my meals under the door until the bag can come off. So you have to understand. So this woman, she was, showed up with, very well made up with long nails. She had a really great outfit on, very concerned about appearance. And so she couldn't imagine what it'd be like to kind of be herself while she had this colostomy bag. People tried to cheer her up by saying, hey, there's lots of really great colostomy underwear out there. You'll be able to dress up, you'll be fine. This was not comforting to her. What did work was that she and I had a conversation about how adjustment takes time, that I couldn't promise her when that adjustment process was going to happen, how long it was going to take, but that based on psychology research, we know that it was going to happen and that we could do things to help increase those chances. And then she looked at me and said, looks like I'm going to have to do this my way. And that was right. And so when I went to visit her post-surgery, I saw her in her hospital bed with, 3 or 4 other people around, balloons tied to the bed, and she was all well made up and looked very much herself. So my hope for you is that this information helps you find your way through difficult times, and thank you so much for your attention.
I've been an oncology dietitian here for well over 15 years. I'm board certified in supportive oncology and nutrition. Next slide. So nutrition, although I'll be speaking of generalizations after surgery, it's definitely an individualized science. As you can tell from all the previous discussions, a lot of talk of specific genes and diseases and diets and the cancer itself and what can be individualized for patients, as well as post-surgery or during and after chemotherapy treatment, what a patient is tolerating as far as diet goes and how we can best maintain nutrition, hydration, and overall good quality of life. So I did like the little quote from Thomas Edison back in the day. Said the doctor of the future will no longer treat the human frame with drugs, but rather cure with prevention, disease with nutrition. So well ahead of its time and a big part of not totally preventing or curing, but at least we're a huge part of that. Next slide. Thank you. Many bowel surgeries, not enough room to put as many bowel surgeries as can happen and rearranged anatomies. But I did just lift a few where you do have things like just the resections where there's no ostomy bags or anything and maintain a good amount of large and small bowel. You also have different ostomy placements, whether it's in the colon or the ileostomy. Some have a jejunostomy. So there's all types of amounts of bowel length, which can affect absorption and hydration, which we have diet recommendations that become individualized for each of those bowel surgeries. Next slide. So the goals of nutrition and exercise, both post-surgery and during treatment, are basically maintaining quality of life. One of the biggest factors in many patient responses is actually related mostly to exercise as well as nutrition, but being able to maintain a good quality of life with activity and feeling well and being able to do the things they want to do. And with nutrition, we try to do that as well. We want them to recover faster, minimize fatigue, minimize weight loss and lean muscle mass, which is both takes the nutrition and the exercise component for rebuilding muscle and being able to work that muscle out as medically appropriate. We want to maintain their nutrients, which can affect many aspects of the way the person feels, fatigue, appetite, and all those things. Maintain hydration, enhance bowel motility, so trying to control whether there's too much bowel movement or whether there's not enough, and doing that with nutrition as well as sometimes needed medications. Better tolerate the side effects of treatment, and lower risk for any infections in the process. Next slide. So just a short, brief intercept on pre-op nutrition. So prior to surgery, there's new things that we're trying to do as far as minimize fasting and including things like immunonutrition. We want to optimize nutrition, hydration, and weight stabilization just so it can help with the post-op recovery. Impact Advanced Recovery is one of the most studied immunonutrition supplements from that we recommend before surgery for 5 days as well as after surgery for 5 days. It contains arginine, which is an amino acid, which helps with immune system and healing and increasing blood flow to help with that healing process. Omega-3 fatty acids help with stress and inflammation, as was spoken to before. And dietary nucleotides, which help rebuild the immune cells and can help with fighting infections. So giving you the best immune system going into the surgery as well as helping it afterward. There are challenges with this, as it can be a costly formula, and from patient responses, the taste is not the best. If it's just something that's not tolerated, we do encourage things like a high protein supplement similar to Ensure Max or something equivalent. Next slide. So as far as immediately post-op nutrition, you'll go to the regular floor. We do try to advance the diet either the day of or after surgery, pending any GI symptoms or concerns that may be from the surgical team and the following team, primary team. The goal is to advance to a fiber-controlled diet. Some may go to a regular diet within 48 hours as medically appropriate, again, monitoring for symptoms. I mentioned the Impact AR for 5 days post-operatively. This is also, even though it's a creamier-based supplement, it's still compliant with the Clear Liquid diets for post-surgical nutrition. Gum chewing is encouraged to increase bowel activity. It's been shown that chewing gum can help with the bowels to re-stimulate them. We do recommend regular gum, not a lot of sugar alcohols, because the ingestion of too many sugar alcohols can cause diarrhea. Oral rehydration solutions, basically we use drip, drop, or Powerade and salt, and I'll speak more detail on those at a later slide. And diet education for those going home on the fiber controlled for about 4 to 6 weeks. If a patient gets admitted to the ICU post-surgery, we do, some may need a core pack for short-term nutrition. And again, we will use the immunonutrition-based enteral feeding or tube feeding. And if they need longer-term feeding, they can adjust after the 5 to 7 days post-op to a regular formula. Next slide. As far as discharge nutrition, the nutrition immediately after surgery is going to be way different than long-term recommendations for some patients. Some patients may still need a GI soft, is what we call it, gastrointestinal soft, or fiber-controlled diet. So we don't do a lot of roughage after surgery just because so much of the bowel has been manipulated, and feel that it just gives the bowels a little chance to heal versus adding a lot of fiber to stimulate the activity in the bowels for some people. You may be, small meals and snacks are recommended, and we recommend complex carbohydrates versus simple carbohydrates. So complex carbohydrates are more of the refined, which again is not going to be the long-term diet that would be recommended. And simple carbohydrates are sugary-based items, which may draw more fluids into the intestine and aggravate diarrhea on some patients. Use of high-calorie foods, so people that aren't having issues with a lot of diarrhea or dumping out of the ostomy bag, we may encourage a little bit of sugary foods if it's well tolerated for the need of added nutrition in the short term. You also might have some higher fat foods that are recommended, again, for the same reason. Some people will require nutritional supplements to help with maintaining their nutrition and hydration, and at times an oral rehydration solution will be added. Next slide. Bowel surgery, when you have part or all of your bowel removed, it does increase the risk for fluid losses because you have less area absorbing, particularly in the colon area, but it does start to absorb again for most people. And what we do are some of these electrolyte solutions with the mixture of little amounts of sugar and the salt. It absorbs better than even water itself. Drip Drop is one of the newer products that we carry, and these aren't endorsed by anybody. It's just a product that we carry, as well as we use, we have several different recipes of either using Powerade or Gatorade with additional sodium, or diluted juices with the addition of sodium to create that perfect osmolality for absorption for patients to decrease dehydration. Next slide. If you do have an ostomy, I just labeled a couple here. For an ileostomy, it's coming out of the ileum. So average output should be between 800 and 1200 cc's per day. Typically, that means a bag, an ostomy bag that's half full, you will empty it 6 to 8 times would be normal. Oatmeal or applesauce is the consistency of the ostomy output, and anything above that, then we're starting oral rehydration solutions and different things to slow down that bowel activity. A jejunostomy is a little more challenging. It may have higher output than an ileostomy, is monitored closer by the physician and dietitian teams, and it will be more watery in consistency. Whereas colostomy, coming from the colon, it's more like a regular bowel movement and typically less than or equal to emptying the bag about 4 times per day is the guideline. Next slide. Long-term healthy behaviors. So basic guidelines are here to help reduce the risk of cancer and other chronic diseases and try to prevent that cancer recurrence and give the best optimization. Implementing between 4 to 6 weeks post-op. My little nuts taken over some of the animal meat. So the New American Plate from the American Institute on Cancer Research recommends, it's not a vegan diet, but it is, a third is from animal protein, lean meats, and 2/3 should come from whole grains, vegetables, fruits, nuts and seeds, and plant-based type foods. Next slide. Mentioning the plant-based foods, the legumes, dried beans and lentils, whole grain breads and cereals. When you look for breads and cereals that are whole grain, it should include the word whole. Sometimes that's confusing because labeling can be deceiving, and it may say multigrain, or it may contain mostly like refined type starches, but just a little bit of wheat in it. So you have to be careful of the labeling. It should say whole grain or have the word whole. More fruits and vegetables, 5 to 9 servings a day, and we do say having a good variety of color in those fruits and vegetables. Next slide. This is also from the American Institute on Cancer Research. They have great information on like foods that have the potential for, benefiting fighting cancer. And so they list, this is just a few that they have on their website. And when you click on it, it does give the reason why it's a recommended food that may have anti-cancer fighting benefits. Next slide. Long-term healthy behaviors also include avoiding processed meats, so lunch meats, hot dogs, bacon, sausage, cured meats and smoked meats are thought to, with those processes, contain some carcinogens. So that's avoiding the processed meats is the best recommendation. Limiting red meats for less than 18 ounces per week is the current recommendation, and not to overcook them. There's still, the jury's out on the carcinogens with cooking, but they feel that overcooking and charring foods could increase the risk for carcinogens. Choosing lean meats and trimming the excess fat, so limiting the foods that are high in saturated fats and trans fats. Trans fats are those fats that were once oil, and hydrogenated is another word for those. So once those become hydrogenated, the body recognizes them more as a saturated fat, which can cause increased challenges with different illnesses as well as cancer potential. Animal sources are high in saturated fats. Low-fat dairy products are recommended. And as I mentioned, the hydrogenated oils. Next slide. Inflammation promoters. So omega-6 is not alone a promoter, but a diet high in omega-6 and lower in omega-3 and not a good ratio like that could cause more inflammatory conditions in the body. So what's recommended is if you are eating some omega-6 fatty acids, which are listed in the slide, to include a good amount of omega-3 fatty acids and fats to balance that out. Other anti-inflammatory foods that we look at with the omega-3 fats is the phytonutrients and antioxidants, which were mentioned with the fruits, vegetables, and whole grain slide. Herbs and spices, I do put a little note at the end of the slides that use with caution. Natural in the regular form is recommended. The pill form, there's questionable ingredients in some of those, and we just recommend with your different treatments to watch that. Probiotic foods are not found to be beneficial in immunotherapy in some studies, whereas fiber foods during immunotherapy has shown to have some good response to the immunotherapy, so we do encourage the fiber in the diet. Next slide. Avoid alcohol, avoid smoking. I'm trying to go through these a little fast here. So achieve and maintain a healthy weight. I know sugars have been mentioned as an inflammatory process. In cancer studies, sugar is also noted to be more related to increasing the risk for obesity, which increases the risk for cancer. So there may be times during treatment we may say add sugar and add different things, and it's not going to, increase your risk for cancer during those times, but it may be more important to maintain weight versus eliminating those calories and losing weight and lean muscle mass. Physical activity recommendations, 75 to 150 minutes of moderate exercise and 150 to 300 minutes of, 75 to 100 of intense exercise and 150 to 300 minutes of moderate exercise weekly. It helps with hormones and insulin levels, which they feel can be beneficial for cancer and tumor growth. Strengthen the immune system, mentally and physically help with digestion and weight control. Next slide. This is just a view of the way vitamins and minerals are typically absorbed when we have an intact gastrointestinal tract. And typically, unless there are certain vitamins that may need added in at some time, if there are extreme losses or there's certain areas, for example, the terminal ileum is where B12 is absorbed, that you may need a B12 injection. So when part of the colon is removed in other areas, we don't, typically the other areas of the gut that's intact will be able to absorb those nutrients. So I would follow up with my doctor and dietitian on those things. Next slide. Again, always check with the physician first before starting vitamins, minerals, or herbs, because these can interfere with different chemotherapy treatments and may not be appropriate. Food sources are definitely preferred and have less interference to any treatments. Need more studies. Calcium has proven to be beneficial in colorectal cancer, but a high calcium diet can be a negative for prostate cancer. So there's different things to look at in the whole scheme of things where it becomes individualized. A lot of the vitamins, herbs, and minerals are not FDA approved. So going to an appropriate website and making sure that it's something that has in it what it's claiming to have in and does not have additional ingredients in it that you don't want to be ingesting. Next slide. Food safety, just touching on that post-surgery and during chemotherapy, is being cautious because your immune system may be affected somewhat. So following, good cooking temperatures of foods and no cross-contamination and maintaining cleanliness and keeping foods at the right temperature is all helpful in decreasing the risk for getting other bacterial problems with your treatments. Next slide. These are all side effects of cancer treatment that dietitians can help. We have good information individually and generalizing on things that can help with these different side effects during any cancer treatment you may be getting. Next slide. Reliable resources is a must. So there's a lot of information out there, and everybody's heard of a friend that had something, or they read this on the internet. And always check with your doctor and dietitian. Investigate using reliable resources, which I have listed at the bottom and on some other slides. Be cautious with extravagant claims and watch a multitude of claims that say they will treat many illnesses. Memorial Sloan Kettering and National Center for Complementary and Integrative Health both have really good information on herbs, vitamins, and different studies that may be out there on that. Next slide. Other reliable resources to use would be different cancer websites that have are based on evidence and studies. And next slide. And these are some of my resources and references. So thank you all for allowing me to participate, and I will be available at the Q&A.
Again, thank you for having me today. My name is Naoki Umeda. I am from a department which is called Wellness and Preventive Medicine. There is one center inside that. It's called Integrative Medicine and Lifestyle Medicine. I wanted to talk about some nutritional supplements, but also maybe some of you are not familiar with, what is the integrative medicine? So I'd like to share some information about that first. The slides doesn't. Oh, okay, it's working. Thank you for waiting. So our philosophy, what is the integrative medicine? You may have heard of the word. It's called holistic medicine or integrative medicine, which means integrating several things, which is one factor is that we call it mind-body connection. As you know, if your mental aspect, it can affect your body or vice versa. So we look at your whole, one unit, whole person approach. So that's our philosophy here. That's the holistic medicine, what holistic medicine means. So also we talk about the mind-body work and also exercise and nutrition, also how to improve your sleep, how was the spirituality, and also anything natural. For example, natural supplements, or maybe when appropriate, we can use some vitamins or other hands-on therapy such as acupuncture. I wanted to share some information about that as well. But just in a general overview, we believe that you are what you eat, the food as a medicine, which has been well explained by the lots of doctors in the past, like 100 years ago or thousands of years ago. So our care team in the integrative medicine, we have physicians like myself, but also we have hands-on therapy people like acupuncturists. Some of the acupuncturists do the TCM, which is the traditional Chinese medicine herb. Most cases, this is not appropriate use for the cancer patient because it may interact with the chemotherapy or immunotherapy. But we see variety of disease, variety of patients, such as having migraine, or non-cancer patients, such as migraine or anxiety, depression, irritable bowel syndrome, joint pain, muscle pain, or rheumatoid arthritis, something like that. So those people may be benefited by using some herbal medicine. We have the Tai Chi instructor and also chiropractor and the massage therapy. They are the hands-on treatment people. And also we have the holistic mind-body psychotherapist who does meditation or deep breath technique, guided imagery. But I'm sure there are lots of excellent psychotherapists or psychologists in the cancer center. So, but some are overlap. But we see cancer patient, but a non-cancer patient as well. we have dietitian, and also we have the yoga instructor as well, because the yoga, we believe the yoga is beneficial to improve the joint flexibility, muscle flexibility. Also, it has some calming or relaxing effect. So that's really the philosophy of the embodying the philosophy of our holistic approach or whole person approach. Regarding the cancer, especially when we apply the integrative medicine for the cancer patient, we call it's integrative oncology. But we should be very cautious about that. So that means there are some statements. Dr. Jun Mao is the chief of the integrative medicine of this Memorial Sloan Kettering Cancer in New York. Using the complementary and the alternate medicine, something natural, instead of the conventional treatment can have a negative impact, bad impact on the clinical outcomes and the survival. So we are aware of that. And actually, sometimes I see where the patient comes to like, oh, I was diagnosed with a cancer, but my oncologist recommended chemotherapy, but I don't want to do the chemotherapy. I only want to take the alternative medicine, such as herbal medicine, or some internet research, such as high dose vitamin C infusion. We are not doing that. But how I respond is the alternative medicine cannot cure the cancer. So alternative medicine means doing this kind of our approach instead of the chemotherapy or immunotherapy or conventional treatment. That's what I don't recommend. I would say, oh, please reconsider. That's a bad idea. So we don't do the alternative medicine. So the integrative medicine and the alternative medicine are different. So this alternative medicine cannot cure the cancer. However, our integrative medicine, holistic medicine approach can help you feel better physically and or mentally during the treatment and after treatment. So mainstream treatment should be definitely the conventional treatment, but we can do something supportive. So that's our role. So, but actually some patients, not many, few patients have kind of misunderstanding about that. So I wanted to clarify about that. So we get the referral inside our department. We do the internal referral between physician, chiropractor, acupuncturist, massage therapy, sometimes nutritionist or yoga therapist, and also meditation specialist. And also we get the referral from other departments, like family medicine or general mental medicine, their primary care doctor, or pain management. For example, people who has fibromyalgia or spine issue, they get the pain medication, but they also want to do something different approach. So that could be beneficial. Rheumatology or oncology surgery for the cancer patient, and also palliative medicine, sometimes OBGYN people like that. So we try to interact with the other department as well. Regarding the integrative oncology for the cancer patient or cancer survivors, actually there are in the major cancer centers, such as they have the integrative medicine center, such as Dana-Farber in Boston, or MD Anderson, Houston, Texas, New York City, Sloan Kettering. They have the integrative medicine or integrative oncology center here. So they have the physician like here, and also acupuncturist, and pretty much similar to what I do here. So the question here is, when is the appropriate timing to consider or apply this integrative medicine or holistic medicine? My simple answer is anytime. Generally, when you are diagnosed as a cancer, then you start researching the internet, or you may find, maybe something supportive approach like an integrative medicine may be beneficial. So you may do the surgery or chemotherapy, just really the conventional treatment. But from our side, maybe more meditation can be beneficial. If you start a chemotherapy, or if you have a side effect, maybe acupuncture may help to relieve the side effects of the treatment, or even after the treatment as a cancer survivorships. Yes, how to live better. If you have overweight or obesity or blood sugar problem, cholesterol problem, how can we do something to prevent not only for the future cancer, but also heart disease or brain disease like a stroke or other metabolic syndrome, we see those people as well. So we can apply our approach kind of anytime. But mainly, most of the patient I see will be these people are doing under the active cancer treatment. So this is the very good outline of the provided by the Dr. Mao from the New York Sloan Kettering Hospital, integrative medicine physician. So we talked about the lifestyle management, and also when appropriate, we can discuss about the herbal medicine or supplements. So which means if I feel, oh, this is good to take or this is not too good to take. So sorting out, that's our role. And also for each symptom, cancer-related symptoms or treatment-related symptom, pain or fatigue or insomnia or maybe neuropathy or GI issue, there are several clinical study has been done for like say acupuncture, massage or meditation like that. But as you can see, one of the information I wanted to share with you today is maybe acupuncture might be good to try for multiple symptoms such as this pain or this fatigue or nausea, vomiting, neuropathy, or even dry mouth and the hot flashes. Or basically this is for the like a breast cancer patient, but so that not related to the colon cancer, but the other symptom, pain, fatigue, GI issue, neuropathy, it could be worth trying. Recently, the ASCO and there's a society which is called SIO, Society for Integrative Oncology, and ASCO published joint guidelines as to the how to control the pain. What is recommended from the integrative medicine side. So let's say for the general cancer pain, the acupuncture has been studied, reflexology or acupressure, massage therapy might be good, or yoga might be good. Even guided imagery, this mind-body work, it may help. There are some evidence, some could be low evidence, some could be intermediate, but there's a lot of study has been already done actually, like from the Sloan Kettering or MD Anderson. CIPN, the chemotherapy-induced peripheral neuropathy. Yes, acupuncture may help, or reflexology or acupressure might be beneficial. So there are lots of clinical data. So we always make a decision or recommend something based on this clinical data and the clinical evidence. So again, just briefly, I wanted to mention about more about acupuncture. We have 6 or 7 acupuncturists in our department. Everyone's equally excellent. Everyone is equally well experienced for the cancer patients or cancer survivors. And definitely if a strong pain, like a joint pain, muscle pain, back pain, or headache, migraine, acupuncture may help to relieve the pain. Also, the neuropathy. Yes, chemotherapy-induced neuropathy. There are some data from the multiple myeloma patients or breast cancer patients. So far, colon cancer patient has not been, there's no, not much good evidence as the study, not studied a lot. But generally, acupuncture can be applied for any kinds of cancer. So if you're not sure if it is good to try now or not, maybe if you could make an appointment with me and I can explain more about it. One thing interesting is also the Dr. Bao from the Memorial Sloan Kettering. She did some questionnaire for the breast cancer survivors. Did you know that the Memorial Sloan Kettering has the acupuncture service? And actually, lots of people didn't know about it. Oh. So I didn't know even that exists in my hospital. So nearly 40% or 50% didn't know about it. So knowing that we have the acupuncture, that kind of option is also maybe beneficial for now or even for the future. Other challenge, as you know, it could be lack of insurance, cost, because lots of insurance unfortunately do not cover for the acupuncture. It could be out of pocket. So that could be one of the big challenge regarding the acupuncture. But so letting you know that, oh, this is acupuncture is worth trying. That's one of my roles. Although I don't do acupuncture, but personally, I'm a huge fan of the acupuncture. So now I'd like to, maybe you have more interest in like, is there any good herbal medicine or any vitamins? Why I am doing the chemotherapy or after the treatment? So we do the counseling for that. As I mentioned, our role is to let you know this vitamin is good to take now, and these vitamins or herbs are not appropriate to take now. So sorting out, that's my role, that's my job. One thing, maybe you have heard of this ginseng. This is originally from traditional Chinese medicine. It's been used for thousands of years or even longer as an energy booster, and it has been a lot in the cancer patient as well. So even during the chemotherapy, it can be used to fight the chronic fatigue or brain fog. But always please talk to your doctor or consult with me. Is it really just to confirm, is it good to take now? Some palliative medicine doctors are very familiar with it. They recommend or prescribe the ginseng as well. So that could be also the consulting to the palliative medicine doctor could be very beneficial as well. One thing I wanted to emphasize is when you are on the immunotherapy or even after the head therapy, ginseng should not be used. The reason is ginseng can use as an energy booster, but also it may enhance your immune system. Then as you know, the immunotherapy is to boost up your immune system to fight the cancer. So if you add the ginseng, your immune system gets too much or too effective or too strong. And there's a risk. It may cause something called autoimmune disorder, which is your own immune cells start attacking your normal tissue, like a joint or skin, which is called autoimmune disorder. Even so, during the treatment, definitely no. During the immunotherapy, definitely no. But even after that, if that is 1 year ago or 2 years ago, 3 years ago, history of the immunotherapy treatment, I do not recommend that. So that's something. So it really depends on the situation. So please always consult to your doctor or consult to our integrative medicine specialist. Other possible beneficial vitamins, vitamin D can be beneficial. It may be good to fight the fatigue, or it may relieve the pain, or if you're feeling anxiety or depression, it may improve your mood. So if your doctor find your vitamin D is low in your blood work, maybe starting some vitamin D could be beneficial. If you're not sure how much to take, yes, please talk to us. We are happy to help, suggesting how much to take. Fish oil, yes, which is the omega-3. There are some data, especially for the cancer survivors. It may help to improve the overall cancer survival. Turmeric, you may have heard, it's a herbal medicine. It may relieve the joint pain. It's a good natural anti-inflammatory. But again, let me emphasize that turmeric is not always okay to use. Really, it really depends on your condition. It really depends on what kind of treatment are you receiving now. So please always talk to your doctor or consult to us. Melatonin, which is the sleep medication, natural sleep medication, as you may know. Magnesium can be, usually this is safely used for multiple things. For example, it has some relaxing effects. So it could be good to reduce the anxiety or stress, or it may relax or the muscle cramps or muscle relaxant. And also it may help to improve your sleep quality. So this is our department phone number. So if you make an appointment, please call us and we are happy to help. Specifically, I wanted to mention about the melatonin because maybe most of you have heard of it or maybe have used it. Melatonin can decrease the time to fall asleep, and it may increase the total sleep time and also improve the overall sleep quality. Those could be about ranging from 2 to 5 milligrams, taking 30 minutes before the bedtime, rather than right before the bedtime. Actually, if you take it 3 minutes before or 60 minutes before the bedtime, that could be more effective. the mechanism of the action is likely to restore the circadian rhythm, which is your wake-sleep schedule, the internal rhythm. So balancing your circadian rhythm, that's the melatonin can help. If you have a seizure disorder history, I don't recommend that. Some people, not all of them, may experience some side effects or some uncomfortable reaction, which is like a vivid dream or wild dream. Still, we don't know why that happened, but if you experience something like this, I don't recommend to do it again. It's not a side effect. It's not something bad is going on inside your brain, not like that, but just your body just doesn't agree with the melatonin. It just happened without specific reason. It's not related to any serious medical problem. If you are interested in some maybe sleep teas, as a tea, they are available as a tea bag, maybe valerian root or passion flower root could be good, or chamomile tea is good, or lemon balm, or peppermint, or licorice. These are all kind of herbal things, but this tea, the amount of the herb is quite very, very minimum. So drinking as a tea, using a tea bag, I'm sure it doesn't affect any kinds of cancer treatment. So it has some, maybe you may experience some relaxing effect. Essential oils, I'm not sure how many of you have used it, but actually the sense of smell can have a very big impact. I mean, a good way, in a positive way for your mood or energy-wise. So for example, certain oils or aromatherapy could be good. For example, bergamot, it may help, it has a relaxing effect. It is good to release the anxiety. Rosemary could be good as a fatigue, to remove the fatigue. Frankincense, it may stabilize your mood. Eucalyptus, especially in the wintertime when the air is dry, some antibacterial effect. So you can put this, you get the the oils like this, maybe put in the diffuser and put in your bedroom and just spread it out all night. It may help. So lavender may help to relieve the pain, or peppermint also may help to relieve the pain. So there are a variety of essential oils, and generally these are safely used for most of the people. So this is the outline of we call it holistic self-care. So there are several options you can do by yourself, or you can talk to our provider, our specialist, like acupuncture. You can receive the acupuncture, or you can learn about the yoga. We have the video as well. Maybe you need some spa or foot bath using the Epsom salt. It could be good to relax your muscle. As I mentioned, aromatherapy could be good, or breathing technique, mind-body work. It may help like this. So there are multiple options. So really, what to choose, it depends on your condition. Your condition can be different week by week or month by month. So depending on that, we are happy to help to sort of make a tailor-made plan, a supportive treatment plan for you. As a summary, integrated oncology is a patient-centered and evidence-informed field. So again, we always think about the evidence. We will make a decision or make a recommendation based on evidence or clinical data, which is the comprehensive care, cancer care using a lifestyle modification, mind-body practices, or natural products alongside with the conventional trend. When you use the integrated medicine, please consult the specialist if you're interested in, especially the nutritional or vitamin supplements. We should use a caution to avoid the possible drug, herb, or drug supplement interaction. Other approach, acupuncture can be beneficial. It's been studied a lot in the multiple cancer center. It could be beneficial to relieve the cancer co-occurring symptoms such as pain or fatigue or nausea, vomiting, peripheral neuropathy, or dry mouth. So I think that's about it, and thank you for your attention.
Thank you so much, Dr. Umeda. That was really fascinating. We'll go on to questions. I looked through some of the questions, and one of the questions that came up to one of the previous sessions when Dr. Macaron spoke to us about NSAIDs and that are being used to reduce the risk for polyps and colon cancer. A question that came up was about turmeric specifically, in terms of helping with as an antioxidant, I guess, to reduce polyps or colorectal cancer. I know you mentioned turmeric in your talk about for joint pain. I was wondering, do you know of any evidence about turmeric and its effects in colorectal cancer specifically?
To my knowledge, not much, to be honest. Right. Theoretically, it has an anti-inflammatory effect, so that makes sense. So I kind of agree, but as to the clinical research data, I have not heard much about that. But I will take a look. Thank you for suggestion.
Okay, great. So then another question that came up, again, going back to the Solendec a little bit, and maybe that's a good question for Marianne to take, would be, we have a question here that my wife has FAP, has no colon or stomach. She takes 250 milligram tabs of Solendec daily. Should we be concerned that a limited GI tract is reducing the absorption of Solendec? Should we be doing anything different with her dosage, such as crushing the tabs, taking a liquid or patch form of Solendec?
Yeah, I'm going to have to defer that. I would defer that to a physician or pharmacist.
Right. So you know,
from it depends on what remaining gut, that's 150, and what areas would be affecting that absorption.
I think you had one slide about sort of the different vitamins and where they absorbed, and
right.
You know, the general rule is that in terms of medications, the majority of medications, I can't speak to all of them, but the majority of medications are absorbed in the small intestine. So in general, even if without a stomach or colon, absorption of most pills happens in the small intestine. Now, there are some extended release formulations that people with stomas sometimes will see some of the pills or all of the pills even in their stoma. So generally what I tell my patients is to keep an eye out and see if they see completely undigested tablets, you know, in the stool, you know, that could be a sign that they're not absorbing it. But generally, when people have most of the small intestine still intact, most of the pills should be absorbed. Anyone
That's
else?
the same. I'm sorry, I was going to say that's the same for like vitamins and minerals. It's mostly duodenal, jejunal absorption. So thank you for speaking on that.
Great, thanks. And then the next question we have here about the effect of intermittent fasting after surgery. Would it help or hurt? So either Marianne or Dr. Umeda, either of you want to talk about intermittent fasting?
I can just, I don't know about any studies post-surgery and for what amount of time. I know there's studies out there about intermittent fasting and helping to delay tumor growth. But as far as post-surgery, we actually are the opposite. We're going for early recovery after surgery. So we want to feed closer to surgery and we want to start feeding sooner after to get gut motility going and avoid like ischemic bowel or any GI issues that way and promote healing and prevent infection.
Great. Dr. Umeda, any thoughts about intermittent fasting? It seems to be like a trendy type of diet that people are doing nowadays.
Yes, I think this has been gathering lots of attention for many people. Actually, one of the frequent questions I get from the cancer patient or cancer survivors. Right, I basically agree. Right after the surgery, I don't recommend that. What I know about the intermittent fasting is there are some doctoral researchers somewhere in California. They are using, I just forget the name, but one of the famous doctor. He's doing a clinical trial for the past few years. Still, definitive evidence has not been published yet. But one study is during the chemotherapy. By doing that, it may help to relieve the side effects of the chemotherapy. But again, there's no proven data yet. Sounds like a promising data, but still not yet. Also, cancer survivors, like all of the treatment is done maybe 1 year or 2 years later, then how to promote the overall health. And intermittent fasting, it could be used to maintain a good body weight, or if you have the metabolic syndrome, like a high cholesterol or obesity or diabetes, it may be beneficial. So I basically only recommend to try it or consider it when your overall condition is stable after the treatment. During the treatment, very cautious. At this time, I don't recommend that because still not much data.
Great. Thank you, Dr. Umeda. Lastly, another very good question here about people get irritation from the Sollendak they're taking. Like with other NSAIDs, it can sometimes cause irritation after taking them. Do you have any suggestions for people who get irritation, GI irritation from taking NSAIDs such as Sollendak? Anyone? Dr. Umeda, Dr. Sommovilla, perhaps?
So sorry, I don't. Regarding a certain foods, I don't know of any certain foods. Well, the only thing I can think of is licorice tea might be beneficial. Using the licorice supplements I don't recommend that because it's not always safe, especially you are during the treatment, during the chemo, after the chemo, during the immunotherapy, there's no proven data. Like I cannot guarantee for 100% is it safe. But drinking tea, it could be very tiny amount. So it may soothe some GI irritation, but still there's no proven data. But probably doesn't hurt the body. So I think it is relatively safe to try licorice tea.
Thank you. All right, I think we'll move on, but just one last question that I do want to get to, which is an important one, and I think Marianne can answer that. You know, we put people on restricted diets after surgery. We tell them they should have a low-fiber diet, which is kind of restricted, but then they end up having other foods. So there's a question here, are lower-fat dairy products recommended even though they are higher in sugar? So there's always some compromising you have to do when you're on restricted diets. So, Marianne, what do you think about low-fat dairy products that are higher in sugar, or would it better be to stick to high-fat dairy products that are low in sugar?
Right. Which way do we go?
Yeah.
No, I still, the guidelines actually recommend the lower fat dairy products, and the sugar source is the important part. So we used to have people avoiding milk and fruit juices and things like that, but those are all natural sugars that have very beneficial properties to them and nutrients. What we're looking to avoid as far as sugar goes are the added sugars, the refined sugars that are added to the product. And dairy is considered one of those minimally processed foods, just like a canned vegetable would be or a bag of spinach, because it has been processed in some form. So as far as dairy products go, the lactose in it is the sugar. It does not have the added sugar. So what we do as far as the whole sugar cancer regime, there's a lot of good myths and truths on that, is try to avoid the insulin highs and lows. So we say if something's more like a simple sugar or more easily absorbed, do it in the context of a meal to slow that absorption of the glucose into the system to kind of keep your insulin levels balanced.
You know, we organize this day so that we can provide education to our patients here in our center, but really we learned so much from our patients that it made sense to have at least one session where we could have a few patients on to share their story and help teach us about what they've gone through and really what we can do better to take care of patients with hereditary and young onset colorectal cancer. So we've had 3 patients who have been kind enough to come on here and share some of their stories and answer any questions that might be available. And so I'd welcome Jody, Allie, and Kathy. If you like to, you can turn on your cameras or at least unmute yourselves. I will ask each of you to introduce yourselves, and I'll have a couple of questions that I'll ask you, but I also encourage our other patients, as you hear anybody talking, to please put any additional questions into the chat box. So I guess for each, I'll go one by one, but for each of you, if you could just share whatever you're comfortable with about your story, and maybe just tell us, just to start, maybe tell us one thing after going through what you've gone through, something that maybe you wish you knew beforehand. So Jody, why don't you start?
Hi, my name is Jody, and I'm from Michigan, and so I would drive to Cleveland Clinic to get um, to get cured, I should say. And my surgeon was Dr. Liska, and so I was diagnosed with colorectal cancer in 2015, and I was 36 years old, and I was a mom and a wife. I had I have two daughters, but they were 2 and 6 years old then. And you know, I was trying to think, I want to like not talk too much, but also give kind of like my background. I did I had a lot of bloating, and I knew something wasn't right, something was up. And then when I had blood in my stools, when I went to the urgent care in Michigan, and they did tell me, like, they came back after some scans and said, you have colitis. So they told me they thought I had colitis. And so they gave me medicine, and I was taking that, but I just still wasn't feeling better. And I don't know, I just in my head, with a little bit of things that I looked up online and stuff, I felt I didn't have it. But it took me a while to keep going to doctors. And when I finally had a GI doctor, I felt like I had to almost like really advocate that I didn't feel like I had colitis, and they finally did a colonoscopy for me, and that's when they found the tumor in Michigan. So then we decided to go to Cleveland Clinic, and but yes, I had colorectal cancer, and the tumor was it was with part my rectum and colon. So I did radiation for 5 days on my rectum before I had the surgery. And I was stage 1, and it didn't go into any of my it was stage 1, and then Dr. Liska was able to get everything. So I did I wrote down a few things I didn't forget. So yes, I guess I should say he was able to get everything, but I had a colon resectional, and I had a ileostomy, and I had that for like 4 months. And then they did the resectional surgery, and or I should say, after my ileostomy, I ended up actually getting C. diff, and I had that for 5 months. And then finally, when I was able to come back to Cleveland, I had a fecal transplant, and that got rid of my C. diff, and now I'm healthy and living. And a lot of those I've just really, I guess I think this is amazing to offer for the young colorectal patients, because I felt very, I was shocked, and felt alone, and I didn't, you don't really know what to ask. And the Cleveland Clinic is amazing, and people would ask, like, do you have any questions? But you wouldn't even know like what questions to ask. So to offer all these things, it's just amazing for people. I ended up, it did put me into menopause, and I'm still, trying to figure that all out right now too, because, you're in your 30s, and you're not expecting to, be in menopause. And so like, if anything, I would say to people, like, I ended up going to a counselor and a therapist, which helped me a lot. It took me a long time to finally go, which I wish I would have done that during all of my, going through cancer. I wish I would have gone earlier for that. I do yoga now. It's helped me so much. I do CrossFit, working out, and pay attention, more to what I'm eating, of course, try to eat organic and try to eat whole foods and less labels. And a lot of the things they were all talking about, that I'm actually interested now in, like, the acupuncture. I've always had migraines, and maybe that can help me there. And just kind of everything that you guys are offering for patients is amazing. And I'm going to be able to I'm cancer free 7 years in December, so I'm still going through figuring things out as well. So this is awesome. So thank you.
Thank you. And I think you brought up a lot of good points about things that we need to kind of keep in mind about our younger patients who present with symptoms, that we can't just poo-poo them because they're young. And certainly, you know, if you had not gotten a colonoscopy when you did, things could have been a lot different. And so, and then I think you also bring up a lot of good points about all of the kind of additional systems that we need to help support people as they're going through their treatments and everything. So thanks a lot, and we'll come back. I just want to get to our other two folks now too. So
Thank you.
Ali, would you like to talk for a little bit about your experiences and about things that you might have wished that you had known before you went on your journey?
Yeah, so I would call myself probably fairly healthy prior to being diagnosed. I'm kind of a big sports person, and so I was very active in everything that I've done since I've been little. Started having symptoms, kind of the same, blood in my stool a little bit, obviously, fatigue, started losing weight, things like that. So I got diagnosed when I was 25. I'm 31 now. And it was a huge shock just on the fact that no one in my family had this. And so I have FAP, I guess I should say, obviously, FAP Gardner syndrome. And so it was just like, what in the world is this? I mean, I was clueless, or my family was clueless. Luckily, my mom kind of got on the ground and did a bunch of research and finding like where we need to go. And so she helped me a lot and really found the Cleveland Clinic team for me. And I really can't say enough about the team. Margaret has been unbelievable, and everybody really has. And they've kind of helped me through the process as I've just finding out all these new things. And so I guess what I wish I would have known is just been probably a little bit more open to, I guess, learning more about it. I think at the beginning I was a little bit angry, I was mad, and it was more of just kind of a, what do I have to do? My head's down. I'm just going to go do it. The surgeries for me happened really fast. So when I got diagnosed at 25, it was late. It was like November. And then I think I had my surgery to remove my rectum and colon in December, like a month later. So it was super quick. And so I didn't have a whole lot of time to think about it. But anyways, since then I have developed, so I have a J pouch. I have developed desmoid tumors. I have done 8 treatments of Doxil with that. And so they've responded fairly well. They've decreased a little bit. And so now I'm kind of on a wait and watch. I'm off of any treatments at the moment. But it has changed like my whole digestive system and kind of lifestyle, but I've just tried to adjust the best that I can and kind of move forward. But again, I do want to reiterate the team at Cleveland Clinic. Like, just for example, it was 2020. I was having a blockage. I needed a bypass essentially, and Dr. Church at the time was my surgeon, and Dr. Sommovilla actually was in on that surgery as well. And I called Margaret up at 7 a.m. in the morning because I was really struggling. And I was like, I luckily enough knew a friend that flies a private jet. And so I called Margaret at 7 a.m. and I said, hey, if I'm there in like 2 hours, is there any way you could fit me in? Because I'm in trouble. And she was like, come on. She got in contact with whoever she needed to, obviously. And it was like a life-changing deal for me. And so I had surgery, was in the hospital for a while. And I don't know if Dr. Sommovilla remembers this, but I think I did not get released until September 23rd. And I had basketball practice that I coach a basketball team. And I told him, I said, October 1st is our first day of practice. And I promise you I will be there and I'm going to coach it. And he kind of gave me a look like I was crazy, basically. And because I know I did not look well. And just to let you know, I did make it to practice and I didn't miss a practice the rest of the season. So anyways, I wanted to tell you that.
Yeah, I do remember, and you know, sometimes patients know best. So thanks for sharing. And so let's just move on to Kathy. Could you share a little bit about your story?
Good afternoon. Thank you for having me. I feel blessed because I have not had cancer. I had gone and went to my medical doctor for just a checkup, and he started asking me questions. And I told him about my mother having colon cancer and my oldest sister and my youngest sister having colon cancer. And he said, "Oh, you're going to have a colonoscopy." And he said, "I know that's not pleasant. And I'm the type of person, suck it up, buttercup, and do what you have to do." And so in 2002, I had a colonoscopy. I think I was 57. And then 2005, I had another one, and that's when my doctor recommended I see an oncologist and have genetic testing. And so they tested me for the other type of colon cancer, and it came back negative. And so Dr. Bufil says, no, it's got to be a hereditary cancer, colon cancer. So they tested me for it, and it's an FAP. And so I ended up, he suggested I go to Cleveland Clinic, which was a blessing, absolute blessing. And he removed part of my colon. And then later on, they were saying I need to have my thyroid gland, a needle biopsy on that, have that. And I didn't understand all about that, but I later on had to have my thyroid gland removed, and it was equivalent to, Dr. Berber said it was equivalent to appendicitis. And then after that, they had me have my stomach checked, and Dr. Burke was my physician for that. And I was coming back to Cleveland Clinic every 6 months to scope my stomach, and then once a year for what was left of my colon. And 2020 is when I, before that, a year before that, Dr. Burke removed a rare tumor. And she said that I needed to go on to Dr. Bott to handle that. And so anyway, I met with Dr. Walsh, the head surgeon, and it was decided when Dr. Bott did a scope on my stomach, the polyps in my stomach were becoming precancerous. So it was decided to remove my stomach. And I had prepared myself because I do a lot of research. And my sister found this book is called The Art of Eating Without a Stomach. And then so I told my granddaughter about it, who's here with me, helping me with a computer. And so she bought the book, and it's called The Art of Eating Without a Stomach, and it's written by Dr. Peter Thatcher, and he's a gastroenterologist. That was so informative. The only thing that he did not mention there is you can't burp. And Dr. Walsh came in after I had my surgery, and he said, "How are you doing?" And I said, "Well, I couldn't burp last night, so I was in my hospital bed. I'm priming the pump. I'm making the bed go up and down, and I finally burped." And he said, "Well, you can't burp because you don't have a stomach." And I said, "I burped." And I thought, well, maybe because I'm on pain medicine, I may be hallucinating. So my husband and I were walking the halls in the hospital after I had my stomach removed, and I burped, and I said, "What was that?" And he says, "It sounded like a burp to me." So the only thing is, that was the one thing I wish I would have known about, but it was no big deal. And trying to think of anything else I've missed. And in the meantime, after I had my stomach removed, in the following January or February, I had my mammogram, and I was diagnosed with breast cancer at stage 1. But I feel blessed. God's taking good care of me. I've adjusted to learning to eat without a stomach. It's not as drastic for me as what I thought it would be. Education is the big thing. Reading that book, and especially sugar has a big effect especially when you don't have a stomach. And so you have to read your labels. You really have to, and even in the fruit, because I ate an orange one morning for breakfast, and that sugar, it made me feel funny, and it was like an overload of sugar. So I have to be very careful even with fruit. I'm trying to think what else. Just like I said, read your labels. And my oldest son was diagnosed with the FAP. He passed away in between having my stomach removed and breast cancer. He passed away, but not from that. It was something else. So I just feel blessed that I was able to be at Cleveland Clinic, and all the doctors and all the people I've dealt with there. They're amazing, and they take the time. They answer your questions. It's just been encouraging for me. I mean, when I have any questions, I just call over there and I get them answered. So, but thank you. And I don't know if there's anything else I've missed. I hope not, but I just encourage people not to be afraid and just live your life. And, there's worse. I mean, I know there's people that, I've not had cancer and I can't imagine what you girls are dealing with. Like I said, mine's all been preventative. So I feel very blessed.
Thank you. Maybe we have time just to go around one more time to each of you, and I know I asked you before if there is something that you wish you had known, but I think it's helpful for us to be educated by you guys, and if you could tell us maybe something that you wish that your providers would know about your experience and that what you go through that would help us take better care of our young and hereditary colorectal cancer syndrome patients. Why don't we stay on you, Kathy, and we could go back around in the reverse order.
I don't know because I've never had the cancer. To me, it's preventative. And if you have any cancer in your family, because I encouraged my oldest sister, the one that had before they did the genetic testing, I encouraged her to tell her kids to be checked. And her son, he ended up he had polyps all through his colon at age 36. And so that he's wearing a pouch and he's adjusted to it. And he's told his mom, you tell Aunt Kathy, she saved my life. So I think it's just about being educated. And if there is any kind of cancer history in your, colon cancer history in your family, you need to encourage people to be tested, even if it's a blood test, colonoscopy. You have to be your own advocate is what you have to be.
Yeah.
Thank you.
Thanks.
Josh, just while Ali and Jody are thinking about your question, I just want to maybe ask Dr. Hurley, one thing I keep hearing and that I heard today again from both Jody and Ali was, when the diagnosis happened, it's a huge shock. And really, we always ask them, like, do you have any questions? And what I hear is that, they feel like they should be having questions, but they don't even know what to ask because it just comes so suddenly. And Karen, do you have any advice for them, for patients like Jody and Ali, when they feel like they should be asking, but they don't know what to ask?
Excuse me. Yeah, it's such a great question. So I think to emphasize that you don't. This is not just your one big shot at getting information. Is one thing I encourage people to do is to form an information plan. Is to see this as a process, and that you're going to be going to multiple sources so that it is okay to circle back and ask your doctors. You can ask, even if you don't have a question at the time, maybe say, well, how do I best get in touch with you when I do form my questions, right? One good way to start to generate questions are to go to patient-oriented websites that are well curated. That might be Colon Cancer Alliance or FORCE or Cancer Support Community that has a lot of rich resources where patients are sharing their stories. That can be a good place to start to generate questions because you hear, oh, this person went through that. Maybe that's something I want to consider. So those would be my two things, and that maybe we as a team start to actively promote the idea of forming an information plan so that we can keep the flow of information as a process.
Thanks.
Would you be able to just kind of repeat your question exactly? Like, were you saying kind of what you guys could potentially
yeah. What do you think? Like you would have told, Dr. Church or myself or Dr. Sommovilla, when it all went down the first time, that what could we have done differently to help you through this?
Yeah, that's a tough question, but I would kind of what we probably said, maybe the process, like just understanding that it's a process that you're like, we are learning our bodies because they're basically new, I mean, different than what I've been used to. And so I think getting used to that was the hardest thing. And then like now, me knowing my body, I know my body like 10 times better than I knew it 3 years ago and even a year ago. And so just learning that process, it takes time. You don't figure it out in one day. And just that flow of there's going to be ups and downs, but just keep going and figure out, kind of figure out ways to manage it the best you can and move on. But that, I would say that was probably the thing that's been big for me.
Okay, is it my turn?
Yeah, Jody.
Yeah. Okay. And I was gonna say, I thought of this after I stopped talking the first time. Like I did all the genetic testing and and I didn't have any of that either. I'm kind of in that category where it's not hereditary. So and I was, same as what Allie said too, like really I played sports and I was active. I was a PE teacher, basketball coach for middle school, and I was very shocked as well, and so I feel like you're just so not, I felt numb, to it all. And like it's always so good to have like a family member or a friend, at least one person go to all your appointments with you because you're just not into write things down. My husband recorded it, he took notes, record everything because I kind of wanted just to be like, okay, where are we going next? And it helped me so much to have him, be so organized and take care of me. And those kind of things are important because you are. And like all in my head, like I just was like, don't know why. I was just like so devastated that I didn't want to have an ileostomy. I did not want to have a bag. And I had to have one. And once I had that, I felt better. I wasn't in the bathroom. I could be with my family because I spent like so much time in the bathroom. So I could be around my kids and I could, you felt like you could live life more. You could go do things and that kind of stuff. So I think like I was just so devastated for that when there could be so much worse things. Like you had such a is it Kathy? Is that yes, thank you. Your attitude just is so amazing. And it just, there's, always think there's someone worse than you, and there is, but Cleveland Clinic is always, and Dr. Liska would tell me like, there will be an end to this dark, dark tunnel. Like it just seems so dark and so long and you feel so lonely, but you can get through this. So I think just seeing people, younger people's faces and all ages faces and people they've gone through, it's like, and it's hard because like they'd ask you, like, what's your pain? And you wouldn't sometimes even know how to answer that question, but I think also it's important to like record. Like I remember when I'd come to how many times do you go to the bathroom? And I'm like, I don't know. I just feel like I'm in there all the time. So, maybe like jot that down. What foods are you eating? What foods make you feel bad after you eat them? Are you, there'd be times where I just felt like it's a new life for me now. It's like when I eat, I mean, I'm going to be going to the bathrooms. Then you have anxiety about, going in public places and where the bathroom's at, those kind of things. So, I mean, it's getting better and you just have to, that kind of thing. But having like the questions, like you said, it's what I'm kind of dealing with now is just like menopause things, and working with that and estrogen and what I need to take and how that medicine kind of affects how you feel and those kind of things is what I'm dealing with now.
Well, thank you so much for sharing. Thanks to all of you, Jody, Allie, and Kathy. I'm sure it's not easy to talk in front of all these people, even if it's virtual, about some pretty emotional experiences that you've gone through. So with that, I will turn it back to Dr. Liska. That's the end of our kind of planned programming for today. And I think Dr. Liska is just going to take a couple of minutes to tie things up.
Yeah, so I just want to echo Dr. Sommovilla. I want to thank everyone, especially the patient panel just now. This was really, really awesome for you guys to share with everyone. And I know it's not easy, but it's so important. I feel like we learn so much more from our patients than from, many conferences we go to where we hear all these presentations on research, which are obviously important as well, but hearing from our patients really teaches us the most. I also want to thank all the faculty who contributed to today. All the talks that have been given today are recorded, and we will be sharing them on our website. So
Can I add a few things?
Please, Kathy.
I forgot to mention, since I've had my stomach removed, my biggest issue is maintaining my weight. And I was told that I would plateau, but it's still an issue of trying to maintain my weight. And they sent me to a dietitian, and she helped me realize, because I don't have a stomach and I don't have a lot of my colon, that she says you're going to have to be eating more food because you don't have the surface to absorb that. Besides, I get a B12 shot every 4 weeks. But my thing is, I wish there was a support group for people without a stomach, because then because people say, well, they tell me you need to eat more, you need to eat more. It's like, you feel like you're eating all the time, but it's not, you still aren't gaining weight. And if I could be with a support group that could, share what they're doing and how they're managing to maintain their weight, that's my biggest concern for me.
Great, thanks, Kathy. And I agree with you. Support groups are wonderful. And, it's something we had several years ago. It was a support group for FAP patients specifically that Dr. Church ran. And every time we do one of these events, the take-home message we get is that, if we can just organize a support group that works, where people can find a time to come together, that it would be so helpful for everyone, really. Thanks, Kathy. But yeah, like I was saying, I also want to thank the faculty who have come on and contributed with their talks. The talks will be online. If you have friends, family, who might be interested, you can definitely tell them about this. Go to our website, the Y Center website or the Young-Onset Center website. Talk to your coordinators, either the Y Center, the Young-Onset Center. They can refer you to that website. And if there are any questions that come up, we're always here for you, and we're always happy to see you or hear from you. So again, this day is, we do it every year, and it's all about, both educating our patients, but like I said, it's also about us learning from one another and from our patients. So this is a very special, day in the calendar for us, and we look forward to it every year, and we plan to do it again next year, and we'll be sending out save the dates when we have a date for it. So again, thank you all for participating. And please reach out with any questions, and we will be in touch, and we're looking forward to seeing each one of you in person again. Bye, everyone.